और
मैं उनके साथ
मैंने व्हाट्सएप कॉल भी करी, वो भी नहीं मिल रही है।
इधर आओ जरा,
We are live now,
कनेक्ट
ma'am.
करो, इसे मुझे कनेक्ट करो और अनम्यूट करो।
Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by AMOGS Emergency Obstetrics Committee with Gorakhpur, Kora Makhanpur, Jaunpur, Jhansi, Mirzapur Societies of UPCOG and also Bandra and Gondia Societies of AMOGS. It's my privilege to introduce the MOC of today's webinar, Dr. Nutan Upadhyaya ma'am. Ma'am is the past president of Saharanpur OBGYN Society, scientific secretary of SOCS 2003, founder chairperson of Mission Pink Health Saharanpur 2020-23, OXY committee member of Study on Female Breast Diseases from 2020-24.
I think
welcome you, ma'am.
Make it short. Yeah, Saidi, please.
Yeah, it's a privilege to introduce Dr. Pragati Agarwal ma'am. Ma'am is Organizing Secretary of UPCOG 2024, Vice Chairperson of UPCOG Oncology Committee 24 to 27. I welcome you ma'am and I hand over the session to MOCs.
Thank you, Saiti. Good evening, all of you. Today we are going to start our 53rd episode of AMOGS, Emergency Obstetric Committee with Gorakhpur, Kora Makhanpur, Jaunpur, Jhansi and Mirzapur Societies of UPCOG and Bhandara and Gondia Societies of AMOGS. These all webinars are the brainchild of Dr. Sneha Buhar ma'am. I invite Dr. Sneha ma'am to welcome all our esteemed members. Dr. Sneha ma'am.
Let us start the session with prayer.
Yes.
Yes, sir.
Let's. After taking the blessings from Lord Shiva, Lord Ganesha, now I invite Dr. Sneha ma'am to welcome all our members of this webinar. And let me introduce her, though we all know her very well. She is MBBS and MD both from BJMC and Soon General Hospital, Pune, Managing Director, Sukharta Hospital, Maternity, Surgical and Nursing Home and Laparoscopic and Infertility Center.
It's okay,
She has
Pragati.
32 years of
We can
experience.
stop sharing. No,
Okay.
we can stop sharing, Saiti.
Yes, we all know that she is the candidate for Vice President of West Zone. We all have to support her with wholehearted. And now I hand over to Dr. Sneha for the welcome.
Thank you. Thank you so much, dear Pragati. Very good evening to one and all. My respect and regards to all the seniors here. A very warm welcome to all of you. At the outset, let me thank all the office bearers of UPCOG, especially Chief Patron Madam Usha Sharma, and the patrons Madam Meera Agnihotri ji, Madam Chandravati ji, the entire office bearers of UPCOG, right from Madam Raj Bhavija, the patrons, and of course the advisors, Dr. Narendra Malhotra, Sir, Madam Jaideep Malhotra, the UPCOG President, Dr. Sarkar Singh, Dr. Kirti Dubey, Madam, immediate past President, Dr. Sadhna Gupta. Can you all hear me?
Yes, yes.
Can you hear me?
Yes.
Yes.
Yes, ma'am.
Thank you. So, Vice President UPCOG, Madam Sadhna Gupta and Madam Ranjana Khanna, and of course, the Secretary of UPCOG, Dr. Bharati Maheshwari and Dr. Priyanka Garg, the Joint Secretary of UPCOG. Extend my warm welcome, of course, on behalf of AMOGS and the AMOGS President, Dr. Kiran Kurtakurti, Secretary, Dr. Bipin Pandit, Treasurer, Dr. Madhuri Mehgare, and of course, I extend a warm welcome to our guest of honor, Madam Anuradha Khanna and Madam Kirti Dubey. I personally thank all the president and secretaries of all the societies of COG, especially Gorakhpur, Koramakhanpur, Jaunpur, Jhansi, Mirzapur societies of UPCOG and Bandara and Gondia societies of Maharashtra. I welcome and thank the esteemed speakers, Dr. Amrita Sarkari Jaipuriani and Dr. Bharati Maheshwari. I would like to personally thank all the esteemed panelists, including Dr. Savita Agrawal, Dr. Vidya Chaudhary, Dr. Shaili Nigam, Dr. Shikha Shukla, Dr. Asta Agrawal, Dr. Rita Dua, Dr. Babita Shukla, Dr. Niti Dogra, Dr. Manoj Aglave, Dr. Yogesh Sonare, and of course, as I have already said, shared, the entire crew or the entire team of president secretaries who have accepted to be collaborate with AMOGS and AMOGS Emergency Obstetrics Committee. With this, I would like to welcome once again everybody. And as though every time I do not say that now this is the time which is very close, my voting process is going to start in next 1 month. So I, with folded hands, request all of you to please support my candidature, vote in maximum numbers, select your representative wisely. So of course, I request to vote for me. For West Zone, there are 2 posts. So in addition to me, you have to vote for 1 more candidate. So I request your blessings and support for me. And with this, I invite the chief guest for today's program, Usha Sharma ji. Though she, because of some reason, she has conveyed her blessings and of course best wishes to this program and blessings to me in person. So thank you so much, Madam Usha Sharma ji, for your blessings always. So we go ahead and have the blessings of Madam Meera Agnihotri ji, who is such a highly illustrious person with highly decorated CV Madam has got. And she was the professor and head of Obsgyne GSUM Medical College, Kanpur, presently chairperson, Ethics and Research, State Medical Council, president of WWW Foundation, advisor of Women's Health Cell, Ministry of Health, Government of India. And if I keep reading, we will not have much time to listen to Madam. So I would request, Madam.
We are comfortable.
Yes, please guide us and bless us. Over to you, Madam.
At the outset, I extend my heartfelt love and gratitude to all the organizing members. I can see Nutan, I can see Niti, I can see Dr. Maheshwari, I can see Sneha. Usha is not there, Chandra is not well, I know. But I tell you, emergency obstetrics, which you have kept as a subject, it is boundaryless. It has got no boundary. You do a cesarean section, you just do as a cakewalk and come back. And sometimes you are stuck up to an extent which you cannot imagine. Maybe it is percreta or so. So emergency obstetrics is a very important subject for not only to the beginners, but also for the seniors who face these problems many a times. I know that you will be doing a great justice with the subject when Sneha is there and Bharti is there and other person. But still, I have found this opportunity. आप लोग स्नेहा को, भारती को वोट देने से नहीं भूलिएगा. Because this is my humble request that those who are working hard, they must come to the surface. And they have done a lot, need not to count. When the things become countless, need not to this thing. I remember, Sneha, I collect that sequence of events, and whenever there is a lecture, I talk about the breast milk bank, which she has discussed sometimes. I will never forget that cricket match which I played with Usha ji, and I don't know whether I won or she won, but मुझे लगता है मेरे रन ज़्यादा थे. So it was a wonderful program she's arranging. She has got academic, you see, gestures in so many fields, and she is working very hard. And we want hard-working persons who represent us. So today's meeting, we have got n number of the societies joining here. So my request from all of you is that, where is Bharti? I can't see her. She has not joined?
She has joined, ma'am. I saw her.
She's there.
She has joined. She has joined.
The video which is
Ma'am.
open, the chair which is seen. Yes.
यस डॉक्टर भारती, इसी बात में हम आपको भी वेलकम करते हैं। आपका स्क्रीन फिर से नहीं दिख रहा है।
I can't see. Pragati, where is she?
अभी
Yeah, she is here, madam.
अभी बात हुई थी,
Continue.
ज्वाइन तो किया हुआ था उन्होंने। बोली मैंने ज्वाइन कर रखा है और दिखी थी स्क्रीन पे।
No, no.
And
Okay,
we
let
are
madam
just joining.
complete.
I'll again
But-
talk. I
I
think there is some
request
connection
all of
problem.
you to
Yeah.
please
बात
keep
होगी।
your vote reserved for Bharti and Dr. Bhuria. They have worked very, very hard. Bharti has also worked in this MTP committee. We have learned a lot from. She has contributed chapters also. So I extend my heartfelt thanks for your endure in the conference. So, Sneha, please continue working. We believe the non-stop journey which you are taken care of. Am I audible or not?
Yes, ma'am. Yes, you are audible.
Yes, madam.
Now you are muted.
Ma'am, you are audible.
Unmute yourself.
Now you are muted, ma'am.
You got muted. Madam, please unmute yourself. Madam's network is poor, I think. So,
Yes,
Pragati,
yes.
can you hear me?
Yes, 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 ma'am.
Okay. So with these words, I extend my blessings and blessings and blessings with gratitude to Sneha and Bharti both, although I'm not able to see her, but please convey it. और स्नेहा अभी से डिसाइड कर लो कि when you come up with flying colors, so 13th September,
yes.
you have to be there in Kanpur. All the society members, those who are present over here, अगर आपको स्नेहा की और भारती की सक्सेस पार्टी सेलिब्रेट करना है, so you have to be there in Kanpur. Am I right?
100%, madam. 100%.
Yes, ma'am.
Sneha,
Yes, ma'am.
you,
Thank you for your
all the society members, please register, please come and enjoy the presidential conference in which Sunita will be, Tendulkar will be here in a, you see, in a flying chairs with bagels and everything. And we have got 9 presidents on our dais
Yes.
and many vice presidents and presidents incoming, both the incoming presidents, Sneha and Bharti. Please do come, please register. We are ready to welcome you. And again, my blessings are there. But Sneha has told me कि मिठाई आपको कानपुर में ही खिलाएंगे।
बिल्कुल।
मीरा मैडम, नमस्ते मीरा मैम।
कहाँ पर थी तुम इतनी देर से?
भारती हेयर, नमस्ते मैम।
तो भारती, I was talking about you, but you were not there. कहाँ चली गई थी?
वो मैम बीच में एकदम से इंटरनेट चला गया था, अभी दोबारा आया।
चलो,
Sorry.
कोई बात
भारती
नहीं।
मैम,
Yeah.
वेलकम आपका। और
Yeah. So
So
we
I
have
have conveyed the words
She
of
was-
blessings for you. Both of you are very cordially invited, and whole society, all those who are joining here, please, please, please do come to Kanpur. We will give you a hearty welcome, love, social guidance, and a special spiritual obstetrics and gynecology. Thank you very much.
Thank you
Please
madam. Thank
continue.
thank you, madam.
और
Thank you.
enjoy this very, very, very tough subject, I will say. It's not an easy subject. Emergency obstetrics is really an emergency. It may be a cakewalk one day and it may be a, nightmare for us sometimes. So do continue with love and blessings to both of you. Thank you very much,
Thank
Beta.
you, madam.
Madam,
Thank
thank
you,
you
ma'am.
so much for your blessings always. So we would like to go ahead with the introduction and welcome of our guest of honor, Dr. Kiran Kurtakoti, who is the president of AMOGS. By now, I'm sure everybody is very well known to Dr. Kiran Kurtakoti, and Kiran Kurtakoti is now very well known to UPCOG. So without much ado, we would like to listen to his words of wisdom.
Thank you.
Yes, over to you, Dr. Kiran.
Thank you, Sneha, for those warm words. And really, you're bridging the gaps between entire India. Now, last week it was MPCOG, then Kasoga, and now UPCOG. So, fantastic work that you are doing. My pranam to Dr. Meera Agnihotri. Dr. Meera ji, I don't know whether she's logged in or not, but yes, definitely we would like to come to Kanpur. And मिठाई तो ठग्गू के लड्डू खाए बिना जाता नहीं है कानपुर से. So, thank you for that invite. And very, very known faces, Bharti, Namaste, Ranjana ji, Namaskar, Neeti ji, Amrita ji. So warm wishes to all of you on
Namaste,
behalf
sir. Namaste.
of AMOGS, Anuradha ji, Namaste. And very, very nice memories of Varanasi AICOG, Anuradha ji. So कभी कभार वाराणसी भी आने का मौका दीजिए AMOGS को. So we'll definitely come in large numbers to Varanasi whenever you have anything in Varanasi. Thank you so much. And, Sneha, you're doing fantastic work. This is the 53rd episode of EMOC, and I think this is the second term that you are doing as the chairperson of the EMOC committee of AMOGS. And only when somebody is working for AMOGS, he or she is promoted for the second term. And the very fact that you are here as a chairperson for the second term indicates that you are doing great work for AMOGS. And I'm sure that you'll continue to do the good work in Foxy also. And warm wishes to you, to Dr. Bharti ji also on behalf of AMOGS, so that you continue this same thing ahead in Foxy. So thank you so much.
Thank you.
With this short,
Thank you, sir. Thank you.
yeah. So thank you so much. And with this short thing, Sneha, please get on with your program.
Yes. Thank you so much. Coming from the president of AMOGS, and of course, a wiser person, definitely, I would say, it's very, very helpful for all of us to, go ahead. Of course, now we invite the president UPCOG. So today, as I said, Madam Saroj Singh is not available as traveling. So Madam Ranjana Khanna will be representing today, and we want to have words of wisdom from you. So Madam, all of you know that she is the National Vice President. She was the National Vice President for Foxy 2017. She was the ICOG Governing Council member with me also. So we have enjoyed the term together. President of Allahabad Menopause Society, Vice President of UPCOG at present, and of course, so many awards and accolades to her credit. We are really very privileged to have you, Madam. Over to you for your words of guidance. Madam Ranjana Khanna, please.
Oops. Yeah, a very good evening to all the UPCOG and AMOGS members. And it's very heartening that you are bringing together two big organizations together, Sneha. And my pranam to all the seniors. Dr. Usha Sharma ma'am is not here, and so is Dr. Chandravati ma'am not here. But Dr. Meera Agnihotri was there, and she has been my friend, teacher, and guide and everything since I'm from GSVM Kanpur. So it was a pleasure, and it's a pleasure to see Dr. Kiran Kurtkoti. And we had that lovely, wonderful vote of thanks I'll never forget, which you gave in the SAR conference, which Sunita did. And that was just out of the blue. It shows your innovative ideas. And one thing, I've been a die-hard obstetrician for several years. And one thing I would like to say about obstetrics, that it always brings surprises to you. Because what you sometimes think it's going to be a very normal delivery becomes abnormal. And when you think this is going to be very simple, it becomes very difficult to do a cesarean. So you have chosen good topics: difficult cesarean, hypertensive disorders, and of course the medical emergencies for which you are the chairperson. So I think you are working very hard at it, Sneha, and we are all with you. And just go ahead in your endeavors, and I'm sure you'll bring the same amount of hard work into Foxy as you are doing for AMOGS and bringing us all together. That is lovely. So, pleasure to see Dr. Anuradha ji today after such a long time. And of course, Bharti is here. Bharti, all the best to you.
Thank
Remember,
you.
we all are with you. UP is standing strong besides you. So, best of luck and please,
Thank you.
uh, my blessings for
Thank
this
you.
lovely conference.
Thank you.
Thank you, madam. Thank you so much for your blessings always, and of course, the support. With this, we would like to go ahead and have blessings and words of guidance from Madam Anuradha Khanna ji, who is also the past president of UPCOG and, of course, ex-head of the Department of Gynae, Banaras Hindu University, ex-president of Varanasi of Gynae Society, and president of Varanasi Menopause Society, president-elect of chapter. That is old CB, I suppose. That is past president of UPCOG, and Madam has got lots of awards and accolades to her credit, right from the FMS fellowship and WHO fellowship, also the UICC fellowship, and lots to her credit. Madam, we are highly obliged to have you, and of course your words of wisdom. Over to you, Madam Anuradha ji, for your words of wisdom.
Thank you very much, Dr. Sneha, for your invitation. And you are doing a wonderful job. I don't know why you have not won last time. You are a very deserving candidate. You work from the heart. You and Bharti both are doing very well. My best wishes to both of you. We know the subject to be discussed, and know both the candidates from West, Dr. Sneha, and from our North Zone, Dr. Bharti. We all are with you. My blessings are with you. Thank you so much.
Thank you.
Thank you, madam. Thank you.
Thank you, ma'am.
Thank you, madam. That means a lot to us. And of course, with the blessings of God Almighty and the respected seniors, we would like to go ahead with the academic section soon.
Ma'am, I think we'll also invite Dr. Bharti also. She's just be part. Just say 2 words because we have 2 very deserving people, Dr. Sneha and Dr. Bharti together. Ma'am, just 2 lines from you also before we start our
Yeah,
academy.
yeah. Being a UPCOG secretary,
Yes, ma'am. As a secretary of UPCOG, please.
yeah. Being a
Please
UPCOG
do.
secretary, it is really pleasure that we both together we are doing continuously good academic works, and I hope that today's session it will get advantage to our all audiences, and this recording will be continued to everyone. So request everyone, please support for the candidature of Dr. Bharti Maheshwari from North Zone, all societies, and of course Dr. Sneha. She's doing so much of hard work. Congratulations, Dr. Sneha, for keeping all together and for this concept. And thanks to all seniors, all guest of honors, all chief guests, Dr. Kiran Kurkoti, Dr. Anuradha ji, Meera madam, and all UPCOG office bearers. Thank you very much.
Thank you, my dear, and best wishes to you as well.
Yeah.
Thank you. We can go ahead with the academic session. Over to you, Dr. Pragati.
Now we will start our academic session.
Yes, please
The
introduce
topic
the
is
chairperson.
tackling hypertension during pregnancy. And the speaker is Dr. Amrita Sarkari Jaipuriyar. For this, let me introduce our esteemed chairpersons, Dr. Bharat Lanjewar. He is MBBS.
Sorry to interrupt you, just one sec. Though I was knowing that Dr. Kirti Dubey, madam has already messaged me that she is unable to join because each time she has to go for some emergency. That's the very reason I did not invite her. Madam has already conveyed me. Okay. So thank you so much. Please let us go ahead.
Dr. Bharat, he is the president Bhandara Obs and Gynae Society, consultant gynecologist and infertility specialist, and Sahyog Hospital and Test Tube Baby Center Bhandara. He is faculty NDVH workshop Kolhapur. Next chairperson, Dr. Ritu Arya. She is MBBS, MD and FICOG. She is senior consultant of Gynae practicing at Yashodhara Hospital, Cloud9 and Max Hospital, Ghaziabad. She is secretary, Khora Makhanpur. Then Dr. Somna Goyal, she is president, Khora Makhanpur Obs and Gynae Society. She is at present, she is out of country. She is in Phuket. She will not join. Now I invite Dr. Bharat to introduce our speaker, Dr. Amrita. Dr. Bharat, will you introduce? Has he joined?
No,
Dr. Bharat has joined?
No, he is also in emergency. He's operating. We can have the other chairperson.
Dr. Ritu, are you here? Dr. Ritu Mittal.
Go ahead, you can introduce. Let us see who is there.
Okay.
You can go
Dr.
ahead.
Amrita.
Yes, ma'am. So there's nothing to say much. I've been the past president of Gorakhpur Obs and Gynae Society. So let me have
I'm
here
to introduce you, my dear. So Dr. Amrita.
Okay, Dr. Sneha.
Yes,
nothing much to say, please.
Yeah, a very dear.
I introduce Dr. Amrita. I would. It's my honor to introduce Dr. Amrita Jaipuria, because Dr. Amrita Jaipuria, we all know she is a renowned gynec from Gorakhpur, and I know her since my college time. She was my senior, very academic, multi-talented, very humble, and very dedicated foxian, I must say. And best wishes to Amrita madam as for your future, all things what you can do in the ICOG or in the Foxy. And today we welcome you on this very important topic, that is clinical on the hypertensive disease of pregnancy. And madam is the vice president currently of Gorakhpur Menopause Society and past president of Gorakhpur OBGY Secretary Society, and currently she is the secretary of ISOPAP Gorakhpur chapter. So madam, welcome you.
Thank you so much. Thank you.
And in fact, you are asset of UP chapter. I always
Thank you so much. So with all the kind words for me, Bharti, thank you so much for that. And thank you, Dr. Sneha, for inviting me on this prestigious platform. And my regards and respects to all the dignitaries of UPCOG, Madam Anuradha Khanna, Madam Dr. Meera Agnihotri, Madam Dr. Ranjana Khanna, Madam, who have joined and blessed this webinar, and all the presidents and secretaries of the various societies, and of course, my chairpersons. So with your permission, I'll share my screen. So is my screen seen, visible?
Yes, ma'am.
Make it full.
Okay. Is it okay now?
Yes, ma'am.
Okay, so the topic assigned to me is hypertensive disorders in pregnancy. And the hypertensive disorders in pregnancy are leading causes of maternal and perinatal mortality and morbidity worldwide. More than 99% of HTP-related maternal deaths occur in under-resourced settings. Perinatal death and maternal morbidity with HTPs remains major challenges for healthcare providers. We should know the data also. So incidence of hypertensive disorder in pregnancy is 10% globally of all the pregnant women, and preeclampsia is 3 to 5%. But in India, the incidence of hypertensive disorder is 8 to 10%, but preeclampsia is quite high, 7.8%. So this indicates that we need to be very careful when we are taking care of our antenatal patients, and we should be very careful about their proteinuria part and the rising blood pressure and end organ damage. In Asia and Africa, 1/10 of all maternal deaths are associated with hypertensive disorder in pregnancy. Let's come to the definition and classification of this problem. Hypertension known before pregnancy or present in the first 20 weeks can be chronic hypertension. It can be essential or secondary to renal disease. It can be white coat hypertension, or masked hypertension. We'll be coming to their definitions in the coming slides. And hypertension arising de novo at or after 20 weeks can be transient gestational hypertension or gestational hypertension itself, and preeclampsia de novo or superimposed on chronic hypertension. The term severe preeclampsia should not be used in clinical practice, because when we say preeclampsia, it is already a severe form of disease. So preeclampsia is the presence of de novo hypertension after 20 weeks gestation, accompanied by proteinuria and or evidence of maternal acute kidney injury, liver dysfunction, neurological features, hemolysis or thrombocytopenia, and or fetal growth restriction. So coming to the definitions, chronic, that is before 20 weeks, chronic hypertension is detected pre-pregnancy or before 20 weeks of gestation. It is essential, that is without a known cause. It can be secondary hypertension with a known secondary cause, example, a renal disease. White coat hypertension is systolic blood pressure equal to or more than 140 or diastolic equal to or more than 90 when measured in the office or clinic, and the blood pressure is less than 135/85 using home BP monitoring or ambulatory BP monitoring readings. So white coat hypertension is the hypertension which occurs after seeing the doctor. Masked hypertension, BP that is less than 140/90 at the clinic or office visit, but it is more than 135/85 at other times outside the clinic or office. And the problems after the 20 weeks or at 20 weeks, gestational hypertension arising de novo at 20 weeks gestation in the absence of proteinuria or other findings suggesting preeclampsia. Transient gestational hypertension is also a term. Hypertension arising at 20 or above 20 weeks of gestation in the clinic, which resolves with repeated BP readings. Coming to the preeclampsia, it's a gestational hypertension accompanied by one or more of the following new onset conditions at 20 weeks or above. It can be proteinuria or other maternal end organ dysfunctions, including neurological complications, example, eclampsia, altered mental status, blindness, stroke, clonus, severe headache, or persistent visual scotomata. There can be pulmonary edema, hematological complications, example, platelet count less than 1.5 lakhs, DIC, hemolysis, acute kidney injury such as creatinine more than 1 mg/cent, liver involvement, that is elevated transaminases such as SGPT more than 40 international units per liter, with or without right upper quadrant or epigastric abdominal pain. Third can be uteroplacental dysfunction, example, placental abruption, angiogenic imbalance, fetal growth restriction, abnormal umbilical artery Doppler, wave, or intrauterine fetal death. When preeclampsia is superimposed on chronic hypertension, it can be among women with chronic hypertension, development of new proteinuria, another maternal organ dysfunction, or evidence of uteroplacental dysfunction, as already said. There are certain other definitions of clinical significance, that is the early onset preeclampsia or the late onset preeclampsia. Onset before 34 weeks of pregnancy is early onset preeclampsia. Maternal complications are more severe. Low birth weight and fetal growth restriction is very common. In the late onset preeclampsia, it occurs after 34 weeks of pregnancy. Maternal complications are less severe, and low birth weight babies and fetal growth restriction is less common in the late onset preeclampsia. Coming to the etiology of this disease, exact etiology is not known. Possible theories are there. There can be abnormal trophoblastic invasion of uterine vessels during placental development, dysfunctional immunological tolerance between maternal, paternal, and fetal tissues, maternal maladaptation to cardiovascular or inflammatory changes which occur in normal pregnancy, and genetic factors that include predisposing genes and epigenetic influences. A bit of detail about this. The stage 1 is the placental syndrome. And here in the picture, we can see the syncytiotrophoblasts, the inner layer of cytotrophoblast. It is invading the endometrium, the myometrium, and the spiral vessels in the myometrium. So there, the picture on the left side, it shows good placentation, better trophoblastic invasion, and on the right, we can see a poor invasion of the spiral arteries. So placental syndrome is more prevalent in early onset preeclampsia, that is occurring before 34 weeks of pregnancy. And evidence suggests that there is a role of soluble anti-angiogenic growth factors, which we'll see in the coming slides, which is the soluble FMS tyrosine kinase 1 and soluble endoglin, these are higher and they lead to abnormal placentation. Coming to the maternal part of it, it is a continuation of the placental part. There is systemic inflammatory response because of the vasospasm or the vessel spasm. And in response to this ischemia, placental factors are released. They are anti-angiogenic, metabolic, and inflammatory leukocyte mediators, and they are released, leading to endothelial cell activation or dysfunction. And this is the main pathogenesis. There is increased production of anti-angiogenic factors like soluble FMS, like tyrosine kinase 1, and soluble endoglin. Then there is endothelial cell injury. There is reduced nitric oxide synthesis and the vasodilator PGI2. So there is further vasoconstriction. And there is, due to this vasoconstriction, there is activation of systemic vascular coagulation. There is thrombocytopenia and DIC. There is increased capillary permeability, edema, shrunken blood volume, and proteinuria. Vasospasm leads to hypertension, necrosis, hemorrhage, and end organ damage, and increased response. There is also an increased response to vasopressors or renin, and which leads to further vasospasm. There is increased thromboxane A2 by the platelets, and it further causes vasoconstriction. Microscopy of placenta will show endothelial damage, insudation of plasma constituents into the vessel wall, myointimal cell proliferation, and medial necrosis. Defective placentation is associated with development of preeclampsia syndrome, preterm delivery, fetal growth restriction, and placental abruption. So this is a picture showing what I have discussed already, and the risk factors are seen in the stage 1. And in the stage 2, we can see that the pro-angiogenic factors, they are going down. That is the placental growth factor and vascular endothelial growth factor, it has gone down. And the anti-angiogenesis, pro-inflammation, endothelial dysfunction, the SFLT and soluble endoglin is going high. This all leads to systemic dysfunction. Coming to the immunological factor, there is intolerance to paternally derived antigens, which is coming from placenta and fetus, and reduced expression of non-classical HLA-G, human leukocytic antigen G, on extravillous trophoblast in women destined to develop preeclampsia. There is increase in T helper lymphocyte type 1, which is inflammatory. T helper lymphocyte 2 is anti-inflammatory. And there is always a balance of these two in pregnancy. When T helper lymphocytes rise, they lead to a lot of problems, including preeclampsia or preterm labor or pregnancy loss. So histological changes at the maternal and placental interface in those with preeclampsia suggest acute graft rejection. Genetic factors are also responsible. It is multifactorial polygenic disorder, evidence in favor of an increased risk of preeclampsia, which is seen when there is a family history of preeclampsia, mother, sister, twins, and ethnic value is also there. African American women, they are commonly affected. So etiopathogenesis, we have already discussed. I'll skip the slide. And this is the pathogenesis of preeclampsia in detail. And here we can see the fetus being affected by the placental ischemic changes and the DIC, etc., leading to hypertension, proteinuria, severe hypertension, and also placental ischemia leading to fetal growth retardation. So the first thing and the first foremost thing which we do for the patient and the first step we do to prevent hypertension is to look for hypertension. Measuring blood pressure is a good task and it should be done properly. It should be measured in the sitting position with the cuff at the level of heart. Inferior vena cava compression by the gravid uterus while the patient is supine can alter the reading substantially, leading to an underestimation of the blood pressure. Similarly, blood pressures measured in the left lateral position may yield falsely low values if the blood pressure is measured in the higher arm, unless the cuff is carefully maintained at the level of the heart. Bladder should be empty, quiet environment in a comfortable room, patient sitting, not crossing her legs, no tight clothing on arm or forearm, no anxiety, stress, or pain. She should stay silent prior to and during the procedure. No caffeine, smoking, or nicotine in preceding 15 to 30 minutes. No nasal decongestant or eye drops. It's not only the blood pressure, which is the parameter of PIH. We should look for other indicators also, like headache, visual disturbances, convulsions, upper abdominal pain, pulmonary edema, proteinuria, oliguria, serum creatinine, thrombocytopenia, hyperbilirubinemia, liver enzyme, and fetal growth retardation. So this is very, very important. Coming to the certain changes which occur in pregnancy. There is an increase in cardiac output, increase in heart rate, increase in blood volume. There are blood pressure changes, especially the diastolic blood pressure. Because of the decrease in systemic vascular resistance, the diastolic blood pressure goes down. So blood pressure is generally low in early pregnancy, reaching its lowest point around 20 to 24 weeks of pregnancy and returning to near pre-pregnancy levels by the third trimester. So this is very, very important and it should always be kept in mind when we are looking for, when we are examining the antenatal patient. There are changes in blood volume distribution also, and the enlarging uterus can compress blood vessels, particularly the inferior vena cava, potentially reducing the venous return when lying on the back. So hypertensive disorder of pregnancy, for this, we have a gestosis score for the risk assessment. It's a very good tool and it categorizes women in low, moderate, and high risk group. So what is this score? Here is a list of risk factors which we should keep it on our table. Like it takes everything, age, it considers the age, the parity, obesity, whether the patient is a cardiovascular risk, if she has been a case of polycystic ovary, if she has conceived by IVF, ICSI, etc., etc. So it's a big list. I'll not read each and every word of it. But on the right, we can see the points given. It is 1, 2, and 3. Now coming to the score, the risk categories, low risk is score 1, moderate risk is score 2, and high risk is 3 or more. Here comes the role of aspirin. We should advise the patient women at high risk of preeclampsia to take 75 to 150 milligram of aspirin daily from 12 weeks until the birth of the baby. Women at high risk are those with any of the following: hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease as LE or SLE or APLA, antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension. We should advise the women with more than one moderate risk factor for preeclampsia to take 75 to 150 milligram of aspirin from 12 weeks until the birth of the baby. Factors indicating moderate risk are first pregnancy, age 40 years or older, pregnancy interval of more than 10 years, BMI of 35 or more, family history of preeclampsia, or multifetal pregnancy. So here is a big chart, a busy chart, or I would say rather very informative picture of the preeclampsia, which has taken into account the blood pressure, proteinuria, thrombocytopenia, renal insufficiency, impaired liver function, pulmonary edema, cerebral or visual symptoms. And we should take care of everything when we are taking care of the antenatal patient who is hypertensive or whose blood pressure is systolic 140 and above and diastolic 90 and above. We should look for the platelet count, and if it is less than 1 lakh, we should be very, very careful. If serum creatinine is more than 1, we should be careful. So here comes the screening test for prediction and prevention of preeclampsia. So Doppler ultrasound is a very good tool, and a high risk index in the uterine artery when they show high resistance flow. In the second trimester, it is associated with 6-fold increase in rate of preeclampsia. Presence of diastolic notch at 24 weeks gestation in the uterine artery can predict the possible development of preeclampsia. Development of renal dysfunction, increased serum uric acid, and appearance of microalbuminuria, they are observed to be the predictors of preeclampsia. Absence of end diastolic frequencies or reverse diastolic flow patterns in the umbilical artery. Average mean arterial pressure in second trimester, more than 90 millimeters of mercury. A rollover test. This screening test is done between 28 and 32 weeks. After resting in the left lateral position, turning to a supine position, induces a rise in diastolic pressure of 20 millimeters of mercury or more. It is a positive test indicating the tendency to develop preeclampsia. So here is the uterine artery Doppler, and in the right picture, we can see a notch and in the diastolic part. So in preeclamptic mother showing early diastolic notch and decreased end diastolic flow due to high resistance. And on the left is the normal mother's Doppler. So management of hypertensive disorders of pregnancy. Delivery is the only cure of the whole spectrum of hypertensive disorders of pregnancy. One's thought doesn't hold true, and the decision of immediate delivery versus expectant management depends on the severity of disease and rate of progression, period of gestation, and maternal and fetal condition. So coming to the investigations of such patient, laboratory investigation, CBC, general blood picture, urine examination, liver enzymes, renal function tests, platelet counts, electrolytes, and picture of the general blood picture, fragmented RBCs, spherocytosis, reticulocytes, and fundus examination should not be forgotten. It doesn't come in the laboratory investigation. We need an ophthalmologist for this, but yes, it's written. So peripheral smear can show severe hemolysis with irregular damaged blood cells. Hemoconcentration, contraction of intravascular space, and capillary leaking. In concurrent hemolysis, the hematocrit values may appear normal. Thrombocytopenia, platelet count less than 1.5 lakhs per microliter. They are significant, and we should start considering the problem. And when it is below 1, then it is severe. Serum creatinine can decrease 0.4 to 0.8. It is a normal physiological low lowering down in pregnancy. But when there is preeclampsia, the serum creatinine is elevated. So we should consider the physiological dip before. When we see a normal creatinine, we should not say it is absolutely normal when it is near 0.8 or 1. We should look for the serum creatinine which was there earlier, because it can be low in the early time, and now it has started rising. It is still low, and it can go higher in the further advancing months. So we should be very careful when we are measuring or looking for the creatinine. Acute kidney injury, serum creatinine levels more than 1 it is an indicator. Elevated serum uric acid corrected for gestational age has been associated with elevated perinatal risk and uteroplacental dysfunction, but it was not independently predictive of adverse maternal outcome. Liver function tests are very, very important, and elevated transaminases with or without right upper quadrant or epigastric abdominal pain suggest liver involvement. Elevation of bilirubin specifically indicates hemolysis. LDH normal range in females is 135 to 214. LDH is an intracellular enzyme which catalyzes lactate and pyruvate, and elevated level indicates cellular death and leakage of the enzyme from the cells. Urine test is very, very important, and it should be an integral part of the antenatal care. And accuracy of dipstick urine analysis in pregnancy with +1 threshold for predicting proteinuria is poor. +1 proteinuria was, in the various studies, it was not found to be very predictive of the proteinuria. So here we can see the measurements. +2 should be considered very, very important and should be taken seriously. Here we can see the chart. When it comes to trace in the dipstick, it shows 15 to 30 mg%. And when it goes up high up to 4, it indicates that the proteinuria is more than 1000 mg%. So significant proteinuria should be defined as more than 300 mg% in a complete 24-hour urine collection, or when urinary dipstick proteinuria is more than or equal to 2+, and even if +1, it needs to be evaluated completely.
Dr. Amrita, sorry for interruption. Can you summarize? We have very little time, only 2 minutes.
Okay, so it's a very big topic, then I need to run the slides. So there are additional, so I'm skipping proteinuria now, I won't take it much in detail. So renal ultrasound should be done if the mother is having any problem regarding proteinuria, etc. And grade 0 is less ecogenic liver. We should see the renal parenchymal disease, and we compare the kidneys with the liver, and here are the grades. So maternal echo should also be done, and coagulation profile should be done. Maternal echocardiography, a 2-fold increase in risk of longer-term cardiovascular disease and a 6-fold increase in risk of developing hypertension within 2 years of delivery. So echocardiography is important. Cranial imaging is also very important. And now coming to, we can take up the patient seriously. We should take the patient seriously, and we should consider MAP, uterine artery PI, PLGF, and soluble FMS like tyrosine kinase as the markers and prediction of preeclampsia. So initial evaluation, 4-hourly BP monitoring, preeclampsia profile, test for fetal well-being, special investigations, angiogenic biomarkers, and initiation of antihypertensives. Further care, initial admission for preeclampsia or severe hypertension. We should, and if she's not admitted, then plan serial visits to the hospital, home BP monitoring, ambulatory BP monitoring. Everything should be considered depending on the condition. Local protocols should be designed and patients should be told about the clinical signs and symptoms regarding chest pain, abdominal pain, headache, etc. So regarding fetal well-being, fetal movement should be told by the patient, serial evaluation of growth should be done, multimodal monitoring with Dopplers, umbilical artery, MCA, ductus venosus, fetal biophysical profile, and CTG. So this is the chart showing the cardiotocography examination and how to decide the mode of delivery and time of delivery. Delphi consensus, I'm not here to talk about IUGR, but we know that early FGR is less than before 32 weeks and late FGR is above 32 weeks. So the importance lies here that around 70% of women with early FGR will develop hypertensive disorder of pregnancy, mainly preeclampsia. So that was the point I wanted to stress upon. Timing of delivery, of course, we need to monitor the patient, and maternal indications for expeditious delivery, uncontrolled severe hypertension, eclampsia, pulmonary edema, abruptio, signs of imminent eclampsia, HELP syndrome, and deterioration of liver function. Fetal indications, repetitive or single severe late deceleration, short-term variability, biophysical profile, less than 4, estimated fetal weight, less than 5th percentile, and reversed end diastolic flow or absent end diastolic flow, and severe oligoamnios, that is AFI less than 5. So these are the principles of care. We all know antenatal steroids if we are terminating the pregnancy earlier, and postpartum surveillance is very, very important. Just a mention about the antihypertensives. The drugs commonly used are methyl-dopa, labetalol, nifedipine, and hydralazine. Labetalol and nifedipine are commonly used. Labetalol is alpha and beta blocker. 100 milligrams TID or QID can be given easily. Calcium channel blocker is nifedipine. 10 to 20 milligram BD can be given in as slow release tablet or immediate in emergency. So there is no role of bed rest and salt restriction. A word about labetalol: it is selective alpha-1 receptor blocker and non-selective beta receptor blocker. It protects the heart from reflex sympathetic drive, and it causes vasodilatation and decreased peripheral vessel resistance, and there is a decrease in blood pressure. So organ damage, we all know the various signs, and in severe hypertension, lowering the blood pressure, there's a policy. We should not be very hasty in lowering the blood pressure. Aim of therapy is to reduce the mean arterial pressure by no more than 15 to 25%. And labetalol in an emergency can be started with 20 milligram IV, repeated 20 milligram to 80 milligram IV, 30 minutes. Onset of action within 5 minutes, peak at 30 minutes. It is best avoided in women with asthma or heart failure. This is very important. We should remember that. And nifedipine can be given orally, not sublingually, 10 to 20 milligram initial dose to be repeated after 30 minutes. Hydralazine can be started as 5 milligram IV, repeat 5 to 10 milligram IV every 30 minutes, or 0.5 milligram to 10 milligram per hour IV to a maximum of 20 milligram IV. Onset of action 5 minutes, peak 30 minutes, and may increase the risk of maternal hypertension. So we should be very, very careful when we are giving. Esmolol is ultra short acting, but it may be useful as a useful therapeutic agent in obstetrics and anesthesia, but concerns about safety have fetal safety have limited its use. It leads to fetal bradycardia. So Maxilf can be given in imminent eclampsia and eclampsia, and we are all aware about the Zoo-Spans and Pritchard's regime. I will not go in detail about the regime, but we should monitor the magnesium toxicity, loss of tendon reflexes, decreased respiratory rate and urine output, chest pain, heart block. So when this occurs, we should stop magnesium sulfate. And we all know that the antidote of magnesium is calcium. A word about HELP syndrome. It's a rare complication of preeclampsia, and we all know when there is low platelet and elevated liver enzyme. Management: anti-seizure prophylaxis with magnesium sulfate, corticosteroid, increase the platelet count, improve perinatal outcome, platelet transfusion should be done. So the take-home messages are: in area where dietary calcium intake is low, calcium supplementation during pregnancy at the dose of 1.5 to 2 grams per day is recommended for the prevention of preeclampsia in all women, but especially those at high risk of women. This is the WHO recommendation, and I could not mention it earlier, so it is here. And low dose aspirin is recommended for prevention of preeclampsia in women and should be initiated before 20 weeks. And antihypertensives to start around 150 millimeters systolic or 100 millimeter diastolic. But some bodies believe that it can be started when it is at 140 90 by 90 or more. And in hypertensive crisis, oral nifedipine has been shown to be equally effective as IV labetalol or hydralazine. And sphygmomanometer, although a gold standard, cannot be used anymore. So aneroid or standardized digital machines are to be used. Regional anesthesia and analgesia are to be preferred, and fluid preload to be avoided. Strict fluid control at the rate of 80 ml per hour is mandatory. Thank you so much.
Thank you so much, Dr. Samita. I think there is no chairpersons are moved.
Hello.
Yes, Dr. Sneha.
So that was an excellent talk, Dr. Amita. I think Nutan is muted and she's speaking something. But
yes,
I would
I'm inviting you only, ma'am, to just give your concluding remarks on this.
I'm here. That was I know, Amrita. It's a very vast topic, and it's just difficult to cover in 15 to 20 minutes. But that was wonderful, and thank you so much for accepting the invitation in a short period. Okay.
Thank you.
Ma'am, let's hear one line from Dr.
I would
Parag
just like
Biniwale
to
also.
invite Dr. Parag Biniwale.
Yes.
Yeah, go ahead. And of course, I would just, everybody by now knows, the whole India knows Dr. Parag Biniwale as the chair of ICUG, and of course, the national coordinator of AMOGS, and a very dear friend of mine. Parag and me, we have, educated together, grown together. So I'm very happy to have him and, his words of guidance. So over to you, Parag, for your.
Thank you, Sneha. Good evening. I bring greetings from AMOGS, and it's indeed a pleasure to be interacting with friends from the state of Uttar Pradesh. Amrita, I must compliment you for a very, very comprehensive and, each slide had a good message. So it was a lovely lecture and I enjoyed listening to it.
But I had to run it, sir, because...
No, doesn't matter. Doesn't matter. But then the way you spoke about the prevention and prediction, that was really important. Right. Sneha, compliments to you for tying up with the UP societies on such important subjects like hypertension and medical emergencies. The AMOGS committee headed by you is crossing boundaries and getting in touch with other societies, and that is something which is important for exchange of knowledge. My best wishes for the program. I don't want to interrupt the flow of scientific program. My best wishes for the program and best wishes to you for your forthcoming election. Thank you very much.
Thank you so much, Parag. Thank you. That was wonderful to have you. In spite of your busy schedule, you could join. So we are very happy. And of course, thanks to you once. Thank you.
Thank you. And best wishes to Bharti also. I can say
Thank
Bharti
you.
now.
Thank you, sir. Thank you.
And thank you, Dr. Bhatt. Thank you, Dr. Sneha, for giving me the opportunity, and best wishes for you and Dr. Bharti. Best wishes.
Thank you.
Thank you, dear. Thank you so much. Thank you. We can move ahead for the second talk, Dr. Nutan and Pragati. Please introduce the speaker.
Yes, ma'am.
Now the next topic is difficult cesarean section, and the speaker is none other than Dr. Bharti Maheshwari, and the chairpersons are Dr. Ritu Jain. Please show the CV. Dr. Shubha Singh. She is MS GSBM Medical College Kanpur, completed in 1993. She is my senior, and She has done from MBBS from GSPM Medical College.
Has she joined? Can we see?
Dr. Shubha. Dr. Shubha, has you joined? She has not joined.
Okay. Next.
Next chairperson. Dr. Meena Jain. She is Director, Vardhaman Surgical and Maternity Home, Mirzapur.
And she is the president of Mirzapur.
Yes, she is at present. She is the president of Mirzapur Society. Dr. Meena Jain, is she here? And next chairperson, Dr. Ritu Jain. She is the
She has
president.
conveyed me that she is having a high grade fever. That's the reason initially for the inauguration she joined, but now she has left. So
okay.
Go ahead.
Okay. Now I invite our speaker, Dr. Bharti Maheshwari. Please show the CV of Dr. Bharti. We all know her very well. She doesn't need any introduction. She is the secretary of UPCOG and the candidate for vice president of North Zone. Dr. Bharti?
Yeah, best wishes to Dr. Bharti, and we are eager to listen to you, Dr. Bharti, with your vast experience. I'm sure the attendees will learn a lot from you. Over to you.
Good evening, everyone, and namaskar and greetings from UPCOG. And really a pleasure that we have together regularly platform of UPCOG as well as AMOGS for doing good interactions and on the clinical topics. And today's as I am giving the topic that is the difficult cesarean section. So we all know that Caesar is an important part of our obs and gynae practice, and we have to do it in our all regularly in our practice, and it is really that every patient teach us something. So I think मैं शुरू से अपने presentation पे जाना चाह रही हूँ. Okay, I have to go. So every patient teaches some different experience, and always it is a lifelong learning when we talk about the clinical skills of obstetrics and gynecology. So thank you very much. Thank you, Dr. Sneha and all AMOGS and UPCOG team for opportunity as well as for blessings and always good wishes, and special thanks or congratulations to Dr. Pragati Agarwal has doing so much of hard work to coordinate all of us, as well as Dr. Nutan Upadhyay and all societies of UP chapter of today's webinar and all over from different places. So thank you very much. So as you know that all of you have given me best wishes, and I request all of you to please support my candidature for Vice President as June coming year. So come to the difficult cesarean section. We all know that nowadays the incidence of cesarean section has been increased, and I am not going in detail of that, and indication of elective cesarean section, they are very clear. But emergency cesarean section, we have lots of indications, and as well as we have to prepare and we have to do special skills we have to learn to handle the emergency cesarean section. When we come to the difficulties during cesarean section, before that we have to know different types of cesarean sections, what are the common we are doing the practices. So we know lower segment cesarean section, classical cesarean section. So now one question comes, when what are the indications of classical cesarean section? Do we still are in practice of classical cesarean section? So of course in current practices we are seeing very few classical cesarean section, but we all should know the indication when transfers sometimes less space previous cesarean section or structural abnormalities that make lower segment unapproachable, as well as fibroids or anterior placenta previa, abnormal vascular lower segment, mother dead and rapid delivery is required, very preterm fetus in breech presentation. But mostly the indications say sometimes they can be avoided and we can do successfully by lower segment cesarean section. So what are the difficulties during cesarean section one can have? So if you start from the very beginning, definitely first thing difficulties could be the difficult abdominal access, difficulties with uterine incision and closure, Then difficult baby deliveries, difficulty placental, difficulty in controlling hemorrhage, and difficult abdominal closure. So when we talk about the incision, so if a patient had a previous cesarean section, dense incision may have formed between uterus and abdominal wall. So they have been much less likely to have formed if a momentum is placed between her uterus and abdominal wall and at the last operation. So this stick should be used. Excise a scar in her abdominal wall with an elliptical incision. Normally we do. And if the side of this might be difficult to join accurately, then we have to make some raw area and we have to do some scratching and tie them later. Besides that, the different type of incision, we all must know that we are familiar with phenenstein, but we should also know about the Joule-Cohen incision as well as Maillard incision. The Joule-Cohen incision, they are appropriated with less blood clot, shorter operating time, less fever, shorter time from skin incision to birth of the baby. Vertical incision is only used in the emergency access, and Maillard incision can be used if access is restricted due to dense adhesions. However, surgeons should be extremely cautious with an integrity of inferior epigastric vessel. So these are the different type of incisions. Difficulty with uterine incision, of course, it can be occurred partially in the previous cesarean or some surgery is done on the uterus. So we have to dissect the bladder and peritoneum, and adequate deflection to protect the bladder. Curvilinear U or J shape when we talk about the uterine incision, and maximum available space we should use so that it protects the uterine vessel. And beside that, we have used sometimes inverted T incision, sometimes vertical incision, classical C incision, and the vertical incision in very selected cases like multiple previous surgeries, densely adherent bladder leiomyoma of lower segment. So difficult abdominal access, mainly adequate excision of previous surgical scar. It should be done and special care while entering the peritoneal cavity to avoid bladder and bowel injury. Peritoneum to be open as high as possible. And when we are doing the cesarean section, sometimes there is abnormal placentation. So always we should try, because nowadays ultrasound is available very when ultrasound was not there. So sometimes we get some surprises when we open the abdomen and we see that placenta is entirely, we see the many things which cannot be diagnosed earlier. But nowadays we have ultrasound, we should have a good clinical history, and then we should try to get all information pre-operatively before the section. So preoperative checkup and confirmation of placental location. Until he placed low-lying placenta previa, they can give difficulties, anticipate poorly formed and vascular lower segment placenta at incision site, access the membrane by insinuating fingers between placenta and uterine wall, and then rupture membrane to access the fetus. So this is very important. Incise placenta and then rapidly, sometimes you have to incise the placenta and then rapidly transplacental access and delivery. But most of the time we can go without, preferably you're not supposed to incise, and if you can go assist the fetus without incising and by the making the place in the side, then it is definitely more safe. But some place you don't get, then you have to incise. But all things has to be done very quickly. Delivery complicated by floating head and obstructive placenta. So instrumental delivery or delivery as breeze. So these all things can be done when we have a center placenta or anterior placenta. Previous cesarean sections and if there are adhesions, they are common, and the extent of adhesions varies among individuals. In some cases, they are very dense adhesion, and then fetal extraction are difficult. So incision to delivery time is prolonged and risk of complication like hemorrhage and bowel injury is heightened. So bladder, bowel, and uterus might be adherent to the sheath. And the most important aspect of adhesion is to try to restore the normal anatomy as far as possible. So keeping this in mind, every case is difficult. So you have to do this and cut and tie of bands, different bands, and sometimes you need to cut the muscles also. So if momentum is adherent to the peritoneum, clamp that is then cut and tied with vicryl. If bladder is adherent to uterine wall, try to open the peritoneal cavity by cutting higher up. If bowel adhesions are encountered, then separate the bowel from adherent tissue by using sharp dissection. And one often has thick fibrous band extending from uterus to rectus muscle. Those are also tied and cut through a bladder in order to secure easy access to the lower uterine segment. In the event of poor exposure of lower uterine segment, then you need to conduct sometime bellies of rectus muscles laterally, but do not hesitate to call in the help of other specialists and your seniors and perform the hysterectomy sometime in most appropriate accessible location. Another option is a paravesical or supravesical extraperitoneal approach. So we all have to keep all these things in advance, preferably in the mind, and we should learn all these things. If there is a dense intraperitoneal adhesion, then definitely these are mainly in the cases where the previous laparotomy is done. Parietal perineum should be opened high up in such cases. Adhesion should always be divided with the points of seizures directed towards sutures. And then important pointers while tackling adhesions are to stay close to uterus to avoid bladder and open uterus between stay sutures. Bladder adherent to the lower uterine segment. If it is so, because the incidence of bladder injury during seizure section ranges from 0.08 to 0.9%. So most common bladder injury occur in cases of previous seizure. A very common problem encountered in cases of previous operation is that bladder gets adhered to the lower segment. If such is the case, then peritoneum should be incised and uterus about 2 cm above the bladder so that UV fold could be mobilized with a finger or a swab. Absent lower uterine segment. If it is that is a very common in the premature infant or in a placenta previa. So in absent, so these are also causes difficulty, and sometimes in these such cases we do the lower upper uterine incision or classic incision where the secure hemostasis close the serosa to avoid adhesion. Tips to close a classical incision: always close inner myometrial layer, then have the assistant manually approximate the edges, then close the mid portion of myometrium, leaving 1 centimeter of outer myometrium still open. Close the serosa and outer layer using a baseball stitch, which is hemostatic and minimize exposed raw surfaces and thus may reduce adhesion. So this is the tips to stitch the classical incision. Then comes the cesarean with fibroid. Nowadays, very common that patients are elderly most of the time, many cesarean, and they are having the fibroid. So if fibroid is situation near the lower segment at the uterine incision line, it becomes a potential life-threatening problem. In such cases, do vertical lower uterine incision or classical cesarean section. And then cesarean delivery in breech presentation, of course, you have to increase the lower uterine segment exposure and introduce your right hand and find the feet. Perform the gentle breech section and always keep the baby's back upward. Obese patients. Nowadays, many patients we get found it obese. Then it is mostly seen in the studies that when they study, they have compared the obese patient phalansteal as well as supraumbilical vertical incision, and there was no statistically significant difference in incidence of primary outcome and no difference in immediate delayed post-operative complication nor in neonatal outcome. However, patients in the vertical midline incision group are more likely to have a classical hysterectomy compared with the phalansteal group in fusion, and they increase overall median surgical blood loss and increase total surgical time by a median of 30 minutes. So morbidity, obesity with pendulous abdomen, of course, you have to see that the vertical incision increased risk of classical incision in the future. Also, and beside that, increase in post-operative pain, atelectasis, superficial wound, and facial dehiscence associated with a substantial increase in wound infection when compared with the low transfer incision in 23% versus 6% in patient with phalanx incision. And then when you compare it with the lower segment in transverse incision, then you always find that transverse abdomen incision made under the panniculus fold with the warm, moist anaerobic environment would increase bacterial content, leading to proliferation of numerous microorganisms producing a bacterial pool as well as promoting infection. But difficulty in obtaining adequate exposure, cephalite retraction of the panniculus is required. Large joints retracted to contain the edge of the panniculus has been described as a simple, effective, and more convenient alternative. Then in the obese patients, of course, pre-anesthetic evacuation is very important. Low transverse skin incision are feasible and preferred to vertical skin incision. Subcutaneous drains still remain controversial, but closer to the subcutaneous layer is generally recommended. Transverse uterine incision are definitely superior impact future pregnancy outcome and must be the first choice. The dose of thromboprophylaxis need to be higher and adjusted according to body weight, as well as prophylactic antibiotic reduce post-operative infection. Then practical implementation that in a morbid obese patient, when you are doing the cesarean, then standard practice is to position the operating table at 10 to 15 degree left lateral tilt. In obese patient, this is even more important for reducing maternal hypotension and its consequences. The operating table should be constructed to allow this position. And the obese patient are at also risk for the further in future wound infection, disease, endometritis, hemorrhage, anesthetic complication, DVT, fetal delivery delay. So all these things should be keeping in mind. Now come to the difficult cesarean section, difficult baby delivery. Of course, there could be the floating head, there could be deeply engaged head, abnormal position presentation, deflex head, prematurity, multiple pregnancies, fetal malformations, and conjoined. Forceps application and cesarean section, of course, we all should learn, and we should see that it is applied as we do the in the vaginal as a suture. You have to see the transversely slide under pressure to push head towards the incision. Then concavity of pelvic curve towards the fetal occiput. Lower blade is applied first, followed by anterior. Then flex fetal head with traction aided by the fundal pressure. Rounding of fetal head in the abdominal incision, then delivery and control extension. So I have all these videos. If I will get time, then I can show you in the last. These are the forceps application of cesarean section. Then floating head with hydramnios. This is the as to we need to be the safe delivery. An extraction of floating head effective cesarean section for fetal growth restriction of a premature fetus may pose difficulty in extraction of fetal head. So vacuum or forceps. So in such cases you can do, or you can do the fix it by the one hand and then only you can do. And internal podalic version are the technique for sometime extraction of floating head. Cesarean section deliveries in cases where the placenta, this issue, so confirmation of placenta location always should be done. Anticipate poorly formed and vascular lower segment, so modify incision. And besides that, the finding confirmed that laparotomy fetal manipulated into the longitudinal eye in the cases of abnormal presentation. And then you studied by the lateral support membrane rupture, like a drain, allow the head to descend and deliver the after function. Other options, you can manipulate into ostium anterior or posterior position, followed by instrumental delivery and by vectors, forceps or vacuum, whatever you need it. Floating head with hydramnios, of course, a video is there. I can show you in the last. And then extracting impacted head, deep transverse arrest. So you know there are lots of methods. Cesarean section done for later stage of labor or prolonged labor in which fetal head is impacted in the pelvis, and they can lead to worse maternal and perinatal outcome. So what you can do, method to disimpact and deeply engage fetal head, like abdomino-vaginal delivery, the reverse breech extraction, use of head elevator, utilization of non-dominant head for extraction, lowering down the operating table, or insertion of balloon device to disimpact and engage fetal head before an emergency cesarean section, and Patwardhan shoulder first technique. So most of the obstetricians, they do these according to their expertization, their learnings, their practices. But nowadays, Patwardhan shoulder, if you are not practicing it, you can do it. Is very useful. So delivery techniques, push method, reverse breech extraction when vaginal accident pushes the head upward, and risk is the vaginal trauma or increased fetal head pressure if not well coordinated. Pull method, when reverse breech extraction, the surgeon grabs the fetal legs and pull the fetal out, breech first rather than attempting to deliver the impacted head. Often preferred in severe impaction as it avoid trying to force the head back. Modified Patwardhan. If the head is deeply impacted, shoulder or arms are delivered first and then trunk and lastly the head. Useful in transverse or oblique fetal position. Use of a fetal pillow or balloon device here. It is inserted in the vagina pre-op, inflated to lift the fetal head gently towards and minimize the trauma to both baby and uterus. So this is also a videos, and I will try to show you in the last. So Patwardhan technique, you all should know that transverse lower uterine incision and identify the fetus shoulder, and then deliver the arm, anterior shoulder delivered by hooking the arm but gently through the incision, and then the posterior shoulder and the second arm are delivered. Then deliver the trunk and pull the fetus in the breech-like manner, and this is essentially a reverse breech extraction. The fetus is delivered shoulder first, trunk and head. And the delivery of head, of course, is the last part, often delivered spontaneously or with gentle assistance. Then original shoulder first Patwardhan maneuver for back anterior to posterior. Here both you can see the both shoulders deliver first, and then the trunk second number, and then the third limbs and fourth in the last head. So this is the Patwardhan technique, modified Patwardhan technique when back is anterior here. This is the modified maneuver for posterior, where back is the posterior. Then what you have to do, first you have to take both legs and then trunk, then both shoulder deliver next, and then head. So head is always delivering last, but you have to see the first leg or first shoulder. This is according to the position of the bag. So vacuum delivery, all you should know, whenever it is required, it is a very safe, and you can, the floating head especially, you can use the vacuum cup placement and traction, and you can deliver by the abdominal load. Criteria for abandoning procedure, always remember. Then vacuum delivery, of course, the videos I can show in the last. Scissor section in the malpresentation, planning delivery in a transfer slide, always external cephalic version is an option for a membrane intact, but transfer slide to be converted into longitudinal cephalic version is an option through conversion to glute by traction or lift. Prefer knowledge of position of fetal head is important. Liberal J-shape incision in lower uterine segment is usually required if baby is term with or without PROM. Inverted T incision is to be avoided. Neglected transverse lies a dangerous situation, and possibility of extension of the incision is always there. Beware of sepsis if membranes have been ruptured for long. Then in multiple pregnancies, you are doing the cesarean section, always plan the delivery, identify location, just fetal lie and relation, plan delivery of presenting fetus, adequate abdominal and uterine incision. And then of course deliver floating head or breech, whatever there, you have to take care. Orientation may be distorted. Mobilize adequate neonatal support. Double clamp the cord of the first fetus after delivery of first baby to avoid retrograde bleeding from the placenta. Experienced neonatologist, aggressive prophylaxis for PPH. Now, injury to newborn during cesarean, deep or uncontrolled uterine incision, they can do it. So always take care of inappropriate, inadequate uterine incision, tapping the fetal part, difficulty in fetal extension. So this is the also thing that they can be avoided. In the preterm work with your unformed lower uterine segment, of course, in early preterm, the lower unformed uterine segment is thick lower uterine and it is undeveloped. So technical challenges and risk for both mother and fetus during cesarean section. So if lower segment is thick, muscular, of course, inaccessible, then higher uterine contractility, small fragile fetus, and future uterine rupture risks are there. And in the impacts cases, there are difficult incision, increases bleeding, fetal extraction is challenging, risk of uterine trauma, prone to injury during delivery. Then comes to the surgical approaches. We do either lower uterine incision, transverse or high transverse incision, or classical incision. We have these three options according to the different patients. We can use it, and they have a different for and cons. So inverted T or J used when transverse incision must be expanded due to difficulty in fetal extraction. Considered last resort if transfers not adequate. So fetal extraction tips, always reverse breech extraction, particularly useful in transverse lie or high head. Avoid excessive traction to prevent intracranial hemorrhage or branchial plexus injury. Deliver slowly and gently to reduce trauma. Post-operative care is always important. Avoid trial of labor in such cases. Warn about uterine rupture risk. Provide contraception counseling as well as monitor for PPH and infection. Now come to abnormal placenta. This is nowadays, because many cases are previously therein, having the placenta previa. If such is there, then definitely chances for adult placenta is more. So how to control lower segment placentation? Bleeding, figure of 8 suture in the placental bed. Use oxytocin and misoprostol simultaneously. Direct injection of prostaglandin F2 alpha. Besides that, low vertical, avoiding the placenta on one side if placenta location is anterolateral. J or T-shaped uterine incision can be given for placenta shear down. And classical uterine incision, of course, one option, and go through placenta, it is also one option. So these are the different difficulties during cesarean due to abnormal position of placenta. If there is morbid adherent placenta, then non-surgical management, leave the placenta in situ, or ligation of uterine internal artery, fluoroscopic bilateral UAE, or organ beam coagulation for hemostasis, insertion of occluding balloons in the internal artery. And otherwise, you can do cesarean hysterectomy and partial total section of bladder, subtotal hysterectomy with removal of large part of placenta, and prophylactic occlusive balloon catheter in internal iliac artery. So in every patient, depends on the bleeding, depends on the situation, only you have to take the decision. And on the last, the hemorrhage. Whenever you are doing the cesarean, and if there is a hemorrhage, it could be because of many reasons. So always it is a challenge to manage the patient successfully. So first important step is you have to anticipate the things. You take all preparedness, you have all necessary arrangements. Strategy to minimize intraoperative blood loss. Loose UV peritoneum is inside and not fascia over the uterine incision. This is a very, very important tip. Avoid wide lateral dissection of the bladder. plan the uterine incision properly. With what I have told you in detail about the abdominal as well as uterine incision. Careful delivering of fetal head to avoid extension of uterine incision. Prefer spontaneous expulsion of placenta, prophylactic use of oxytocin, clamping the cut edge of uterine incision with hemostatic forceps. So control of intraoperative bleeding, lots of these hemostatic sutures, we all know, Beeling sutures, modified technique, Shaw square suture, hem and internal iliac operatic histectomy. So intraoperative bleeding on the localized by always press by the sponge and holder or pack to isolate the bleeding site, and then deep intraoperative suture to ligate bleeding, preferably with chromic catgut number 1. As with delayed absorber sutures, cutting through tissue is common. Then stepwise revascularization, all of you are already knowing unilateral uterine artery ligation, then bilateral at the upper part of lower uterine segment, then low uterine vessel ligation after mobilization of bladder, unilateral ovarian vessel ligation, bilateral vessel ligation. Then B-link sutures, we all are having nowadays lots of workshops, lots of trainings, and this is very useful, we all know. And in fact, all of you should do practice even in the non-cases of APH and PPH and all, so that you, whenever the PPH comes, you have a practice. Simple, effective, safe, and requires minimal expertise. Women meet the criteria for B-link compression suture if bimanual compression decreases the amount of uterine bleeding by abdominal and perineal inspection. Modified technique and Chow square suture, Heyman modification, they are also equally effective. Then comes to internal iliac artery ligation. Now it is emphasized that if we really want to save our women, then definitely we all have to learn it. Experiments in the effect of ligation of internal iliac artery was to convert the affected pelvic circulation to a venous system, so allow clotting to develop and persist, resulting into control of PPH. Effective in uterine atony, midline perforation, large broad ligament, or lateral pelvic hematoma, multiple cervical tears, lower segment. So this internal ligation helpful in all such causes of bleeding, less effective in placenta accreta, not useful for uterine laceration, manual or so obstetric hysterectomy, this is the last thing whenever you have a raised. So indication for subtotal hysterectomy, you always should know when the rupture of uterus is unrepairable. Indication of total hysterectomy to control bleeding from lower segment of uterus, cervix, vagina. So these was all different situations of the difficult cesarean section. Most important thing is that every patient is give different experience. There is no 2x2 rule or nothing else like that. You can, even you are so much of experience, you can have a case which you were such type of case you have never faced in the past. Experience make us better. Staff training, it is very important. Not you alone can't do if your whole staff, your whole team is not properly trained and not properly well versed with the things. Monitoring of emergency logistics, what you have to always do, and enhancing skills are key for managing difficult situations. But again, anticipation and preparedness, they are the key of successful management. So we all should do it and emphasize it. Thank you very much. And again, as you all have given me so much of support during my MTP tenure, and this is the memories what we have a different our MTP publications as well as things. So I hope that all of you will take care. This is the Surakshit Garpat Beti Bachao ke saath all over country with all of you. And I have seen today the president of Bandara Society, and I was remembering when I myself gone to Bandara societies to do all MTP CME. So thank you very much, and all of us to wishes for saving our mothers and for well-being of our women. Thank you.
Thank you, Dr. Bharti. Really, you have given a wonderful talk, though the topic is so vast and we are facing the problems in day-to-day practice. Now I invite Dr. Sneha to conclude some.
Yeah, do we have the chairpersons? I think we will have I can see Dr. Vidya Chaudhary from Jhansi. Yes, good evening.
She is panelist.
Good evening, ma'am.
Yes,
Panelist.
I know very well. I'm just welcoming her. But then
Good evening, ma'am. Good evening, ma'am.
Good evening. Good evening. I can see all the panelists here. You have already said that Dr. Bharti has, delivered the talk in a very practical way, and definitely the attendees have been benefited. what are the ways out, at what stage, what problem can come and how you should overcome it. So I think that was an excellent talk. You can go ahead, Dr. Pragati, to introduce with all the experts and panelists. I hope Dr. Alka said whether she can join, but by the time you start introducing the panelists.
Dr. Nutan, will you introduce? Dr. Nutan is here. Okay. The next session. Our next session is panel discussion on medical emergencies in obstetrics. And the moderator is Dr. Isneha herself. She has already been introduced. And the panel experts are Dr. Sadhana Gupta. We all know her very well. She is the co-chair.
Is Madam here? Is Madam here? Can we...
Dr. Sadhana ma'am. She was initially,
yeah,
there.
I will call her. No, I can see actually she's here logged in, but we need to call her. I'll just give her a ring. Okay.
Okay.
Introduce the panelists by the time I'll call her.
Please show the CV of panelist. Dr. Ritu Dua, she is MBBS MD and present designation consultant gynecologist and infertility specialist, Mirzapur, City Hospital, Mirzapur. And next panelist, Dr. Manoj Aglave. He is consultant laparoscopic surgeon and infertility specialist, Siddhi Vinayak Hospital, Lakhani, Bhandara. She is ex-assistant professor, IGGMC, Nagpur, secretary, Bhandara Obsceni Society. Next, Dr. Neeti Dogra. She is presently running her own maternity center at Mohadipur. Senior consultant and a team member of obstetric critical care and high-risk pregnancy at Savitri Hospital, Gorakhpur. She has next Dr. Astha Agrawal. She is MBBS, DNB, FMAS, present designation consultant of Gynae, Max Super Specialty Hospital, Ghaziabad. Dr. Bhavita Shukla. She is Vice President, Gorakhpur Obs Gynae Society and ex-secretary, treasurer, scientific secretary of Gorakhpur Obs and Gynae Society, clinical secretary of ISOPAR Gorakhpur chapter. Next, Dr. Vidya Chaudhary. She is secretary, Jhansi, professor of Gynae department, Maharani Lakshmi Bai Medical College, Jhansi, UP. She has been awarded fellowship by ICOG, ICMCH, awarded by Honorable Health Minister for maximum insertion of PPIUCD in Bundelkhand region in 2015. Next, Dr. Yogesh Sonare, he is Secretary, Gondia Obs Gynae Society. Dr. Savita Agrawal, she is Secretary, Gorakhpur Obs and Gynae Society. Dr. Shaili Nigam, she is Secretary, Jaunpur Obs and Gynae Society. Dr. Shikha Shukla, she is from Jaunpur. Dr. Sadhana, has she joined?
Yes, madam is there.
I'm there.
No.
Pragati.
Saiti, please show her CV, Dr. Sadhana CV.
It's okay. ये बहुत पुराना है, it's okay, रहने दो.
आपको तो हर कोई जानता है.
It's fine.
Good evening, ma'am. Sadhana, ma'am.
Hello, Neeti. Hello.
Namaste, ma'am.
Namaste.
Good evening, ma'am.
Hello, Shaili.
She is gold medalist MBBS and gold medalist in MS also.
It's okay, Pragati.
No, let other people know it, madam. It will be inspiring for everybody. Yes.
This co-chair SEFOC NCD committee, Foxy representative to SEFOC 2018-21, Vice President Foxy 2016, and she is director and senior consultant.
Vice chairperson of ICOG.
Okay.
Yeah. Okay. We can stop sharing, Pragati. Yes. Yeah. May I request all the panelists to please put on your video. May I request all the panelists, Dr. Vidya, Dr. Ritu, all of you, please put on your video. I would like to see you.
It is already on, madam. Video is on.
Yes, yeah, because there are many people. No, now I can see Dr. Sadhna madam and of course Vidya. So I will just start with the initial case. We have lots of panelists actually. We have Dr. Sadhna Gupta madam and Dr. Alka Sethi as experts, and we have Dr. Savita Agrawal from Gorakhpur, Dr. Vidya Chaudhary from Jhansi, Dr. Shaili Nigam from Jaunpur, Dr. Shikha Shukla from Jaunpur, Dr. Asta Agrawal from Koramakhanpur, Dr. Ritu Dua. I would request all of you to please put on your video. Dr. Ritu Dua from Mirzapur, Dr. Babita Shukla from Gorakhpur, Dr. Niti Dogra from Gorakhpur, Dr. Manoj Aglave, and Dr. Yogesh Sonari from Bandara and Gondia. So, the topic for today's discussion is medical emergencies in obstetrics or medical emergencies during pregnancy. So I'd like to have your opinion, Madam Dr. Savita Agrawal. Are the medical emergencies during pregnancy are on rise? And if yes, what can be the reason? Madam Savita.
Yes. Thank you, Dr. Sneha, for including me in this webinar. And nowadays, the medical emergencies are rising globally, and there are many reasons for this. The first is the advanced maternal age. Nowadays, women are trying pregnancy between 30 to 40 years because of the career orientation and the late marriages. So with the age between 30 to 40, if the pregnancy is there, already there is chances of medical diseases like diabetes, hypertension, and the cardiac issues. So with the pregnancy and all these medical diseases, the complications rate are high. Secondly, the more and more women are becoming pregnant with the pre-existing disease like hypertension, diabetes, and the hypothyroidism, and the many more diseases which they conceive during in late age. That escalates the pregnancy complications and that leads to many complications.
Right.
Thirdly, because of the use of reproductive techniques, artificial ART techniques, many more women are conceiving after 40 years. So they are associated with many other diseases already, like diabetes, hypertension, hypothyroidism, and many cardiac issues and then they develop many complications like peripartum cardiomyopathy, eclampsia, and the diabetes ketoacidosis, and many times hypoglycemia and all these things.
Yes,
and
so you're right, madam. Yeah, you're right, madam, that yes, the medical emergencies at present, actually in this era, they are on a rise. The incidence is on a rise, and that is because of the changing demography of the obstetric population. As very correctly pointed out, that of age, and that's the reason they're having their associated comorbidities. Even they're becoming more and more of career minded, so living outside, having their stress, so obesity, infertility, and then more and more of the ART pregnancies, that itself they are in their inherent complication, that itself is a high risk pregnancy. So definitely it's not only the incidence that is rising, but even the spectrum is broadening. So with this, we start with the first case now. We have this 36-year-old woman who is conceived after IUI. Her husband stays in Dubai and she stays in a village. But because this is a precious pregnancy, she is registered with the obstetrician, comes to the visit regularly. So everything is done properly. But then knowing that things are fine, she is lost to follow. So suddenly at 34 weeks, she reports to a primary healthcare center with history of upper abdominal pain and edema. So at PHC, when they measure blood pressure, 176 by 116. So mild proteinuria with the dipstick. Other investigations are not done here. So BP was very high. So the medical officer gives tablet nifedipine retard. Okay. And then, he just tells her that she should get admitted to the higher center. This lady did not get admitted on, maybe after 2 days, she got admitted to a higher center, that is sub-district hospital, where again with tablet nifedipine retard, her BP was 168 by 110, that is 110. And so there they started her on magnesium sulfate and just added tablet labetalol. Okay, so because they have the facilities for operation theater, cesarean section, they went ahead with cesarean section. Her seizure was done, and she was continued on tablet nifedipine and labetalol with Maxel. So suddenly, maybe around 10 hours later, this patient had certain severe cough, breathlessness, restlessness. She's had tachycardia. BP was very high, 220 by 118. Oxygen saturation dropped down to. Her chest was full of wheeze, no, clear breath sound. So, what is your diagnosis, Dr. Vidya? I would say differential diagnosis for her, and whether how would you manage her?
Thank
Dr.
you so
Vidya.
much, ma'am. Thank you so much including me. Good evening, all of you, and good evening, all the madam. With this given clinical scenario, she is a case of severe hypertensive disorder of pregnancy, and she developed after the 20 hours of cesarean section, sudden severe cough and the breathlessness, restlessness, hypoxia, wheezes on chest. Most probable with this scenario, because of the pulmonary edema.
Yeah.
It can be because of this hypertensive disorder itself, or it can be because of fluid overload, or it can be because of some cardiac pathology, left ventricular dysfunction, or it may be because of the peripartum cardiomyopathy.
Perfect.
The
So these
most
are
probable is
other
pulmonary edema.
Right. How would you manage this patient?
We have to manage because it is an acute emergency. We have to manage simultaneously with the investigation, and all the management should be done side by side. First, the call for help. Oxygen is propped up the position, maintain the ABC, that is the airway, breathing, and the circulation. We have to, patient should be in upright position, put her on the oxygen NRBM. If it should be put on the NRBM with the high flow, and the circulation should be maintained because she is a case of hypertensive, severe hypertension. We have to give antihypertensive. Drug of choice is injection labetalol. And because pulmonary edema, drug of choice, there should be the loop diuretic should be given, injection laces, because it is the main treatment for this. We have to decrease the overload from the lung. And then nebulization for the wheezes, and investigation should be sent by the side for the arterial blood gas analysis, all the routine investigations, CBC, LFT, KFT, and the coagulation profile, and the chest x-ray for ruling out other causes, and the signs, and ECG, and the 2D echo if available and the patient is stable for the initial management.
Because as you have said rightly, it is a catastrophe. So you have given us differential diagnosis, and all of us have to manage her on priority as an emergency. That whatever management we are doing is just symptomatic, but we have to come to a definitive diagnosis, and that's it why X-ray test, ECG, echo, and even the cardiac enzymes. Because in this age group, you cannot rule out the myocardial infarction. That is also one more possibility. So cardiac enzymes definitely. So with all your supportive management, it's everything is going on. In spite of this, by the time you have called your physician, you called your anesthetist, and they have just started giving her on umbo assisted respiration, and she was being shifted to ICU. In spite of all this, she went into cardiac arrest. Now, how do you manage her?
The patient is in the ICU now. We have to first maintain the cardiac arrest. We have to give the immediately CPR, cardiopulmonary resuscitation,
right,
and put her on the ventilator. And then
details you want to give it to our attendees, how you should give CPR.
CPR, madam, cardiopulmonary resuscitation. We have to give. There is the protocol for giving this CPR, chest compression and the breathing. And if she is in the ICU, we have to put her on the ventilator. We have to give the cardiac compression with the synchronization with the breathing.
Right. So how many, what I want to know, because see, obstetricians, we always feel that it's a job of intensivist or physician. But, when it happens to your patient in your hospital, in your presence, by the time you call for help and that person reaches, you have to take care of all this. So CPR is a must. Even non-medicals must know it. So how many compresses, how much should be the sternum compressed, and how many breathings? How do you give it? What do you want to advise?
It should be given when there is a 3:1 ratio, 3 compression with the 1 breathing till it should be done. And we have to, the hand should be, the elbow should be the extended, it should not be flexed, and the hand should be
sit on right side of the patient only. Yeah. Anybody want
at least 100 to 120 compresses per minute should be given.
Yes.
And at least 2 centimeter compression of chest should be done. That much pressure should be applied.
2 inches, that is 5 centimeters.
Okay, 2 inches. And
It is 2 inches
time
in the lower part of sternum.
Yes,
lower part of
perfect. Dr. Babita, you also want to add something? Please go ahead.
So, ma'am, CPR, like as you said, everyone should know it properly. So the patient is on the floor or on the OT table. First of all, you put one hand over the other, put it in the lower part of the sternum. Both your elbows should be straight. And you should put the adequate pressure, because if we just keep on doing like that, then it will not be stimulated. So we should give a pressure of at least that the sternum is depressed by 2 inches. That is 5 centimeter, and at least 100 to 120 beats per minute, and in between, like she said, 3:1. So we have to give respiration also. And when the heart rate comes,
she doesn't respond to this, for how much time you want to wait? And if she doesn't respond to this, what next? DC shock, the defibrillator?
It should be for 15 minutes. We can give the DC shock also.
15 to 20 minutes CPR, I think, ma'am.
15 minutes. After that, we have to give
15 minutes. 15 minutes. Yes, Dr. Niti, you want to add something?
Ma'am, we have to give IV adrenaline in a ratio of 1:10. And along with IV atropine every 5 minutes. Along with
1 in 10,000, that is the dilution. 1 in 10,000. Yeah. So how much adrenaline you want to push? And when do you want to see? Yes, definitely.
So actually, it is my case. This is the case I had in 2018, and Niti is also there, because this patient had IUI in our side and they lost to follow up, like Sneha what I said, and they come for, and with the steroid priming, we did cesarean section, and it was okay actually. Patient was okay. But that was a learning lesson for life. That patient had a, like when I took round around 1.5 hours ago, she was taking tea and looking very comfortable. And after 1 hour, suddenly the sister called me that it is she is having extremely breathless, extremely hypoxic, and the oxygen saturation was deteriorating so rapidly that actually it was in a 70%, 60%, 40%, and our anesthetist came and they give EMBO and then the ventilation. And you know that attendant did not go with the patient. And I called ambulance, and Niti is there. Prabhat actually tackled this patient, and I sent this patient on my ambulance from Savitri Hospital with my anesthetist, because their attendant said that the patient is no more, and they were not. फिर वहां पे resuscitation, it was CPR. Immediately she was put on ventilation, and after 5 minutes she get like a heart rate, but for 24, 36 hours, she remained there, and the oxygen saturation improved. But because the attendant were not cooperative, then they paid from the Savitri Hospital, because it is our own society meeting. They referred to Lucknow, and we actually didn't know baby was okay. So what learning lesson I got, because when you know you have these things, actually no theory actually works for you, because you cannot send any investigation. It was my anesthetist prompt present, his first EMBO bag and then ventilation. Then with taking all the risk, our anesthetist went over there, and I also sent my staff, and the people at the Savitri Hospital, they took care. Even like they don't have money to deposit. By grace of my luck and the patient luck, she was revived at the moment. She must be having some neurological injury, and I actually don't know what happened to them, because they were not that cooperative. So they shifted to the government, like Lucknow, to the government center, maybe SGPGF. So important learning lesson what I get, that any patient, what is the practical thing I learned, that any patient with preeclampsia need to be in ICU for at least 72 hours, because after 36 hours, when all fluid overload and all physiological changes are coming back, and what they said, discuss, it was a flash pulmonary edema, and the thing happens with, because the low colloid osmotic pressure in the preeclampsia and all the multidisciplinary thing. So one thing I like a message to all any patient with preeclampsia. I think 2 or 3 patients we have ARDS, but that severity I have never like seen. Still, I feel, like whenever this case is being discussed, that only God is there. I feel, and the anesthetist is like a our like a confide and the thing. So always had a very good relationship, friendship with your anesthetist. Because in all medical emergency, the Sneha is coming out. We actually that respiratory assistance is the thing which is needed. And one thing Dr. Sneha Muar is very, very hardworking, very passionate worker who has kept the Foxy Breast Committee to the great heights. And she's a perseverant and a very dedicated person. And we wish you all the best. And we say that all the people in like our society who are there, who give full-hearted support to Dr. Sneha, so that the hardworking people are encouraged and be at the prime of the like a hallmark of the Foxy post. So thank you. I am there to listen. And when I saw the first case and
साधना जी भारती के लिए भी.
So Neeti Prabhat was there for.
Yes, sir. Yes, ma'am. Yes, ma'am.
Yes.
Yeah. So thank you, madam. Thank you so much.
In severe preeclampsia, after delivery, should be like I usually give Lasix, so that because in cesarean we don't know how much of fluid, though we tell them you give restricted fluid, but then to be on safer side, I do give Lasix after delivery.
The next question is that only. What went wrong and where? Was it preventable? That is a question for Dr. Shaili. So Shaili, right from early pregnancy, see, she is, poor thing, this lady, thinking it's a precious pregnancy, she got registered. She's coming to an obstetrician regularly. In spite of all this, she landed into this catastrophe. Was it preventable? I want to know from you.
First thing, she was lost to follow up. So
the first visit. This lady, you remember, 36-year-old lady, infertile lady, conceived on IUI. So right from, her age.
She is elderly gravida, 36 years age.
Right.
So she has high chances of developing these problems of hypertension, diabetes that we already discussed. So she should have been counseled for regular follow-up.
That is one. But then before that, screening. Where is the role of screening?
Screening for
score, the first trimester anti-scan, the uterine artery pulsatility index, the biophysical and biochemical test to predict, and even the obesity. Yes. So all these things, screening plays a very important role. That is one. So all these tests should have been done. That is one. Secondly, this lady should have been told that you are a high risk patient, and at no point anybody should tell her that everything is fine. Why she lost to follow up? She was told that she is fine. Everything till date is normal. But you have to say that every time we have to assess the risk factors. Every time we have to reassess. Okay, so that is what is one. Secondly, when she reported, even when she reported to that, so what could have been started for? If she was a high risk, then should we have started? Yeah.
Ecosprin should be started.
Ecosprin, so low dose aspirin and high dose calcium should have been started for her. Then she should have been, followed up very regularly. At the earliest point when even the 140/90 was reached, she should have been started with tablet. And what was mismanaged here is when she went to the primary healthcare center, her BP was 176/116. So she was given tablet nifedipine retard. Was that the antihypertensive to be given?
First choice is labetalol.
Is it oral or IV for such severe hypertension?
For such severe hypertension, ma'am, first
it should be admitted. Patient should be admitted with severe hypertension.
Admitted and IV labetalol
and
to
the
be
IV
given.
and
Yes, but then at PHC
the
they
magnesium
don't give
sulfate.
IV labetalol.
And till the blood pressure is controlled, like we give it and wait for 15 minutes. If not controlled, then we double the dose.
At
Till it
primary
is
healthcare center, they are not able to give IV labetalol.
They should have referred the
They should
patient.
have
They should
referred it
refer
to
the
higher
patient.
center at then
So what
only.
is the next choice? You do have a very good choice. Capsule nifedipine 10 milligram. That is a very, very effective drug. Even today, those who, where you cannot give capsule nifedipine 10 milligram orally is a very good choice. The onset of action is within 5 minutes, the peak action is within 30 minutes, and the duration is 6 hours. Okay, so oral nifedipine 10 milligram is still a very good choice. If it is not controlled within half an hour, you can repeat even 10 milligram orally, but definitely strictly no to sublingual. Okay, so that is a message. Okay, that is one. Next time, next step, when it was not given, the tablet nifedipine retard was given, but at least at sub-district hospital, she should have received IV labetalol, right? If not, if you have the intensivist or anesthetist, in fact, nitroglycerin infusion, NTG infusion is the drug of choice for pulmonary edema,
It
right?
is preferred.
Now,
Yeah.
pre-operatively, what steps could have been done, and intraoperatively, as somebody has already talked about, pre-operatively, what could have been done for this patient?
Blood pressure should have been well controlled.
Blood pressure should have been well controlled. That is one. Fluid should have been restricted. See, for spinal anesthesia, we give preload. Fast fluids we give, that should have been restricted. And as I think somebody said that you should give Lasix. If the moment you deliver the baby, you can definitely give Lasix, right? Yeah. And of course, try and absolutely no to methergine. Absolutely no to methergine. In fact, give carbetocin. Okay, and then as Sadhna madam has said, such patients have to be monitored at least for 72 hours in NTU or ICU, right? So that is a learning lesson for all of us. Prediction, screening, and early management. Okay, so now we have this second case for Dr. Shikha Shukla. Do we have Dr. Shikha?
Yes, ma'am.
Dr. Shikha, please. Yeah, can we see her?
Hello.
I could. Hello. Yes, Dr. Shikha, this is a case for you. Hello. Yes.
Yes, ma'am.
So,
ma'am.
yeah. We have this grand multipara admitted to emergency ward at 11 p.m. But this lady, she was as obstructed labor. Her pulse rate was 110, BP was 130/80, and she was exhausted. Thick meconium stem liquor was there. So prolonged obstructed labor with thick meconium stem liquor. Immediately with antibiotics and fluid resuscitation, she was taken for cesarean section. Cesarean section, it dropped also, it was uneventful, only small extension that was also repaired well, and there was no hematoma. There was no, PPH also immediate, even there was no internal or external bleeding. But after shifting to ward, maybe around 1 hour later, she became confused, drowsy, vomiting tendency. Her pulse was very thready and rapid. So, she was having no pallor. She did not have any pallor, no external hemorrhage, and no signs of internal hemorrhage also. Uterus was well contracted. What is your diagnosis? How would you go ahead with the management, Dr. Shikha?
Good evening, ma'am.
Good evening.
As we can see that there is no hemorrhage, but the pulse is low and BP is low. Pulse is 3D.
Yeah.
So we can and it was an obstructed labor. So with the history and by exam, maybe a case of septic shock. Maybe patient would have gone in septic shock. So the pulse is 3D and BP is low.
Do you get septic shock immediately after operative procedure, or maybe it will take some time? And
No,
how do you come to the diagnosis? Please go ahead.
Ma'am, patient was an obstructed labor, and it was ma'am, it was maybe badly handled, so the infections was already there. So we can suspect it's as a confused look.
It actually, yes. I think it's facing some problems, network issues.
Hello.
Yeah.
Ma'am.
You want to take up this case?
Yes. Can I? Hi, ma'am.
Yes.
Dr. Asta here. Can I take up?
Yeah, I think just a moment. I think Dr. Shikha is speaking something.
Okay,
So,
ma'am.
Dr. Shikha, actually, she doesn't have any signs of sepsis at present. Okay. Her immediate pre-op, her vitals were stable. Intra-op, she did not have any bleeding. So, post-operatively, suddenly she worsened. So, it's a catastrophe, right?
Almost embolism.
Amniotic fluid embolism can also be there.
Mm-hmm.
Yes.
But as you know, amniotic fluid embolism is a diagnosis of exclusion, right? So for that we have to rule out everything. So how will you do that? Cardiogenic shock, neurogenic shock, hypoglycemic shock, or diabetic ketoacisis. How will you manage this patient? Your patient is in shock now. Yes. Your patient is in shock. How will you manage?
Yeah.
First we will give, ma'am, fluids, IV fluids.
Yes, perfect.
Yes.
So aggressive
we will give
resuscitation. Yes.
So, ma'am, shall I speak, ma'am?
Yes,
Am I
please.
audible? Yes, ma'am.
Yes.
So, ma'am, in this patient, the patient collapsed after the surgery. So, I could have a differential diagnosis of amniotic fluid embolism, pulmonary embolism, or maybe there is something which we have missed. Like in this patient, she's a grand multipara. She is obstructed labor, and the baby weight is 4 kg. So we have to think about that. Maybe she's having macrosomia. So we have to think about diabetic ketoacidosis also. Apart from this, the other reasons can be shock. Maybe the patient was dehydrated since she was referred from some other center. So we have to, we may not have that much amount of time to assess the history in particular. Because as far as I think this patient was an unbooked patient. So she must have landed up in the hospital in obstructed labor. So obviously, jo bhi gynecologist tha, she must have, the first priority would have been, kind of to save the baby. So to operate as fast as it could be was the first priority, I feel. So the total assessment of the patient, which includes a detailed history, and maybe this patient who was in obstructed labor was not taking a regular antenatal follow up also, because इस तरह के patients generally ना आते हैं तो वो follow up भी ढंग से नहीं लेके आते. That is why they land up into a situation where they have a thick MSL and obstructed labor and refer to a tertiary care center.
But then now that she's presented to you as a catastrophe,
Yes. So first thing is, now that she has collapsed, first and foremost, which comes to a gynecologist's mind is definitely a hemoglobin levels. So I would like to do bedside hemoglobin levels in this patient. Side by side, I would do a aggressive fluid management. Maybe normal saline or DNS can be started. But now the catch is here the catch comes.
Normal saline and
Normal
RS.
saline. Yes.
Yeah, right.
Yes. Normal saline is better because we don't know what is the sugar levels of the patient. So it is better कि हम normal saline चलाएं. Plus apart from that, side by side we have to give the samples for sugars, for electrolytes, for hemoglobin. Meanwhile, if we have the facilities, we should also do an ECG, so that some amount of pulmonary embolism, we can have that S1 Q3 T3 pattern of ECG characteristic. So we will have a little idea whether actually we are dealing with some embolism or whether it is something else. Plus, if there is a catheter which must be there because the patient was operated, so we can send the urine for ketones. Maybe that will help us deciding on the
I'll just stop you here because you have the dipsticks.
Yes, we can do it.
By the time the lab reports come, bedside, yes.
Yes,
So that
we can
is
do
what
a
has
dipsticks.
saved this patient. See, hemoglobin was 10.8 gram %, bedside sugar was very high, 550. The urine sugar was 4 plus and ketones were 3. That is bedside test. Okay, so immediately the physician was concerned. Of course, by the time call for help, shout for help, everything was done. So physician and anesthetist were invited already, and normal saline was in and then immediately diagnosis. Now it is ketoacidosis, and that is diabetes, and that has worsened the situation, and she was undiagnosed diabetic. Okay, so now that normal saline with insulin is started and everything, now it is under your control. But tell me how to manage this part now. You have done the fluid resuscitation. How to manage the diabetic ketoacidosis part?
Ma'am, whenever we are dealing with a diabetic ketoacidosis, we have to try that the patient should be ideally in a tertiary care center if possible, so that
Right.
in case if it worsens, we have ICU setup, we have a endocrinologist at hand, we have a physician who can support us. Plus,
Right.
apart from this, the fluid management is to be very particular. We have to be very particular about the fluid management in such patients. It has to be saline with insulin, and blood sugar charting has to be done. Apart from that, we have to keep on seeing what is the ketone levels. Apart from urine ketones, we can send the blood ketones levels. So a
Right.
ketone level of 3 millimole per liter in the blood ketone is suggestive of severity of the disease. So we should try to keep the ketones
Right.
less than ideally less than 0.6. But if it is because this is a patient which is badly mismanaged, so ekdam se to nahi aayega. So probably less than 3 we can try maintaining the ketone levels in blood. And apart from this, regular post-operative care and antibiotics and everything has to be definitely
Yeah.
done.
So there is what is called as anion gap, right?
Yes,
That
yes,
is
ma'am, yes.
acidosis. So we have to correct the volume deficit. So how much fluid you want to infuse, how much fluid you can infuse over how much time? That is what you need to tell me.
How much fluid?
Yeah.
I think we have to infuse 100.
Large volume, large volume.
Large
That is what is the
volume.
answer for us. But
Okay.
see how large that I will tell you. That initially, basically, sir, the sugar levels of 550 plus. Okay. So naturally, a bolus of at least 10 to 15 units that you know. Okay, minimum of 10 to 15 units. And then, of course, you start the infusion. But on one side, you give a large volume of fluid. So initially, the first hour you have to give at least 1 liter in the first hour.
1,000.
Yeah, so 1 liter, 1000 ml has to be given in the first hour. Then that is hypertonic saline, 0.9%. Okay,
Okay.
and
Okay.
then of course you have to come to the normal saline. And then because why you have to maintain the osmotic diuresis that has led to this condition of dehydration. That's the reason initially give tonic saline and then you come back to normal saline. And then, of course, the fluid which is to be given, I will just tell you that correct 75% of the fluid deficit in the first 24 hours. So approximately 1000 ml per hour for first 2 hours. So two liters in the first 2 hours. And then you come back to 250 ml per hour. That means the pint goes for 2 hours only. That is how you have to correct the fluid deficit and the anion gap. Of course, you keep sending the sugar, electrolytes, ketones, everything, and of course the blood gas analysis also. So that is how you have to manage. Your physician friend, diabetologist is of course there to rescue you. That is not an issue. But yes, definitely when you diagnose, that is a point you have to give the bolus insulin with monitoring. That is what we have to. Now, what is a learning lesson, Dr. Asta, from this case?
So, ma'am, the learning lesson from this case is, as a gynecologist, I feel ki first thing, whenever a patient collapses, we always think about, obstetric person, जैसे कि hemoglobin and PPH, all these things are definitely there. But we have to, think about the medical complications as well. So we have to be very, whenever we are seeing a macrosomic baby, we should be particular. Maybe in the post-operative period, that time itself, they should have checked the blood sugar. Maybe they would have had an idea that the patient is already a diabetic. So these things have to be taken care of. जब emergency होती है, maybe that time we did not have time to send all the investigations. But yes, we should definitely retrospectively also cesarean करके बस we just go कि हो गया है, done हो गया है. But that
I would take you
golden
little before that whenever you have unregistered patient,
Yes,
at least send all the laboratory investigation first and do whatever bedside investigation. Before you
Even if she
take her
has an
to
emergency, we can always do a blood sugar by a glucometer as soon as the patient comes.
That is
So
what I
that is
want
very
to give the
important.
message.
Blindly going you for cesarean, giving 5% DNS and raising the blood sugar and leading to such this catastrophic condition is not wise. Always do.
So that is what. And even before that, I would say that yes, it should be universal screening for
Yes.
Yes, ma'am. Yes, ma'am.
So every woman during every pregnancy should be screened. Whether she has had diabetes or GTM in the previous pregnancy, doesn't matter. Every woman during every pregnancy. And when do we screen that?
At the first
First
visit,
visit,
Yes.
then
And
24 to 28
24 to
weeks
28.
second.
24 to 28.
So even
The
if you
first
differ and all of us follow this, I think that's a very good take-home message from this case. You know, simple, I would directly say it's simple mistake on our part has landed up, you know, led this patient into this catastrophe. Okay.
Yes, ma'am.
So,
Yes.
yeah, so that's a very good take-home message from this case. Now we come to Dr. Ritu. Dr. Ritu, do we have Dr. Ritu? Hare? Dr. Ritu? She's not there.
No, she's there. She's there.
Hello, Dr. Ritu.
Kindly unmute yourself. Dr. Ritu, unmute yourself.
Huh. Or has she joined without audio? Is it? No, we can't hear you, my dear.
We can't hear.
Please check your audio. Please check your audio. This is a case for you.
Can you hear me now?
Yes. Yeah. So I read it for you. This is a case for you. This unregistered primary gravida, married for 2 years. She comes to you with 9 months amenorrhea. Initially, she has, you know, mild fever, little cough, and vaginal discharge. Okay, she's full-term pregnancy. So she was having mild pains, and she, you know, all of a sudden she developed spontaneous rupture of pregnancy. So rupture of membranes. So the obstetrician thought that, you know, let us not keep her pending. So she started her on augmentation with oxytocin. But unfortunately, she landed up into fetal distress. So immediately the decision for LSS was taken, emergency cesarean section. So anesthetist saw this patient, examined. Anesthetist found her diastolic murmur. So she was given regional anesthesia, baby delivered, and suddenly she started becoming severely breathless. What is your diagnosis, Dr. Ritu? How do you classify or grade this condition, and could you have prevented this?
Yes, ma'am. Ma'am, this most probably seems a case of rheumatic heart disease, which is most prevalent in our setup, and mostly because also diastolic murmur has already been mentioned, along with
Yes,
certain
okay.
symptoms like she had breathlessness and cough and tachycardia. So
Right.
most probably this is mitral stenosis. And mitral, because she has breathlessness, so it seems it is moderate to severe mitral stenosis. Most probably the size of the mitral valve is less than 2.5 centimeters square. That is why that is when the symptoms of breathlessness actually appear. So this
Okay.
seems moderate to severe mitral stenosis, and this could have been prevented because if we were just a little more careful, because she presented with fever and discharge PV, there could be have been a confusion that she is there's some but and later on she developed a rupture of membranes, so there could have been a confusion with chorioamnionitis, but and also because there was tachycardia and diastolic murmur at the initial stage was missed, and because the labor was
So what is your
augmented.
message? Yeah. So before that, we will go to the discussion. Dr. Babita, how do you
Yes, ma'am.
classify? She's already said it is
So-
rheumatic heart disease because it's a diastolic murmur and most common is rheumatic. Of course, she's got symptoms even at rest and maybe with little activity or fever. So NYHA grade 3 or grade 4, right? So
Yes, ma'am.
how do you grade the severity?
Yes,
And
ma'am. So, as per the New York Heart Association, we do a functional grading. That is, what degree of symptoms the patient has with some amount of work. So,
Right.
grade 1 patient is asymptomatic, both at routine work and at rest. When the
Right.
patient develops symptoms with routine activity, but she is asymptomatic at rest, then it is grade 2. And grade 3, when the patient is symptomatic in less than routine activity, like she's doing slight work, some walking or something, and she feels breathless. So that is grade 3. In grade 4, the patient is at rest and still she is symptomatic.
Right.
Then we also have an etiological classification depending upon the cause of the disease. The most common, as we say, is the rheumatic heart disease.
Right.
And then we have the congenital heart disease, which may be cyanotic or acyanotic. We have the ischemic heart disease and cardiomyopathy, that is especially the peripartum cardiomyopathy. I mean, it's quite common in some
Quite
cases in
common now.
pregnancy. And others are, we have due to hypertension, we can have hypertensive disease, and severe thyrotoxicosis, we can have due to thyrotoxicosis as well.
Right. So, I mean, for this, definitely, I would just say, as you said, congenital cyanotic or acyanotic.
Yes, ma'am.
Previously we used to have, fallows and all this. Even TGV, too, we used to feel that this child is going to die. But nowadays, the corrected, surgically corrected
They are
TGV,
correctable,
even
yes.
fallows, they are reaching this obstetric age. They are reaching this reproductive age group. So that is adding, quite a risk to our practice also. So, how to come to, see, all of you know that this physiological changes of pregnancy, right from symptoms, signs, even when you examine, and even when you do, echo also, you have certain changes, which are, the shifting of the apex laterally and upwards, all
Upwards.
these things changes, they mimic that of the symptoms and signs of the heart disease. But definitely, as you said, that, make a point to auscultate the chest of the woman. We always say that, as a clinician, it's not only the pregnancy, the fetus is our domain. It's not so. Examine the woman from top to bottom. That is the simple message. So, general physical examination and systemic examination. Don't forget to look for even the liver or spleen. Even if we are obstetrician, examine the patient in details. I think that should pay you in long term, because you're not going to miss anything. That is one message from this case. And then, of course, we have, how you can prevent, whom all you need in your team. This is what is given. So that is not much importance from my point of view. Suppose your patient has heart disease, you know it. So what is the role of preconception counseling, Dr. Babita?
Ma'am, there are certain heart disease which come in severe categories,
Right.
in which we cannot allow pregnancy. So we have to counsel the
What are they?
patient. Like you have
Which are they?
Eisenmenger syndrome, or you have coarctation of aorta, or
Right.
you have Marfan syndrome with aortic involvement.
Right.
So these conditions are really severe, and the patient should actually
One
refrain from going.
more I want to add, that is primary pulmonary hypertension.
Yes, primary pulmonary hypertension.
Right.
And other conditions, if the patient wants to go for a pregnancy, she should have a thorough checkup in the pre-pregnancy period, a proper cardiac checkup, and
Right.
a heart should be in a stable condition. And
Mhm.
during pregnancy also, we should she has to have checkup both from the obstetrician as well as the cardiologist, so that her functioning is normal. We should properly counsel the patient regarding the maternal morbidity and mortality, and she needs a thorough checkup during pregnancy. We should also counsel her the role of investigation, particularly the TIFA scan, to rule out congenital anomalies, and prognosis should be explained. And if the patient develops any symptoms like severe breathlessness, maybe fever, cough, or anything, so this should not be taken lightly. The patient should be admitted and thoroughly managed under such condition. And her antenatal checkup should be more frequent than the normal patients.
Right.
That is maybe twice, every 15 days for around 20 to 30 weeks. And maybe after that, we should go for weekly checkup.
Right.
And this patient should not be allowed to go post-date. And they should be admitted 15 days before the EDD, or any other symptomatic condition. They should be admitted earlier. And hospital delivery is mandatory in such
Right,
patients. They
mandatory.
just can't think of delivering at home, and always in a tertiary center with an ICU backup, so that whenever you need, you can put the patient in ICU.
Right, perfect. So, Dr. Niti, I would like to ask you, Dr. Niti.
Yes, ma'am.
Yes. So, Dr. Babita has very nicely elaborated that very high risk patient, we shouldn't allow them to become pregnant. And there are NYHA class 3 and 4. These are, we need to optimize them. As somebody talked about, the critical mitral stenosis also, we have to, go for balloon valvulotomy maybe before conception. All these things, said and done. In spite of all this, the patient conceives, she maybe purposefully or maybe not understanding, unknowingly. What would be your approach now? Whether you should allow her very severe heart disease, which actually she is not supposed to conceive at all. It is a risk to her life. So whether we should, thinking that, oh, now she is conceived, so let us allow her. Should we do this, or should we advise her MTP?
Ma'am, if the patient, if we have received, in this scenario, the patient, in this scenario, the patient was not advised, like it should not be advised MTP in this scenario because she was tolerating pregnancy well. She precipitated the thing during intra.
Let me
In high risk, we have
let
to
me stop you.
terminate them.
Let me stop you here. Just little interruption here. What
Yes,
I'm
ma'am.
trying to say is very severe heart disease.
Yes, ma'am.
Where actually we are not supposed to allow her to get pregnant. As
Yes, ma'am.
Dr. Papita has said, either those 3-4 conditions, Eisenmenger's, primary pulmonary hypertension, Marfan's, and coarctation. So we should never allow them because it's a risk to the mother's life.
Yes, ma'am.
Okay, but this patient did not listen to you, and she just early pregnancy. Whether you should
Ma'am, if it is,
her,
ma'am, if it is a severe case and if she has come to us at 8 weeks, we can go for an MTP and with the section evacuation. And we have to counsel her that it is also a risk to her life.
Right. So that is what is the, you never go into dilemma. The patient's relatives may manipulate you.
Yes, ma'am.
They may pressurize you that now that, she has conceived naturally, so we don't want to terminate. But anytime you don't listen, you keep on writing that she must undergo termination. You keep on counseling them because, she has tolerated only early pregnancy up to 8 weeks. But the things, the physiological. Listen, what the dictum says that you should never allow pregnancy. It's a risk to mother's life, so we should not allow. Pregnancy termination also carries a risk, but definitely during first trimester to its minimum, right? So we should always advise medical termination of pregnancy for a patient where you actually are not supposed to. That is what is the answer for this. So do we have Dr. Manoj Aglave? Dr. Manoj? No, I think we do not have. Anybody can take up this question. How frequently should the patient come for antenatal care? Dr. Babita has already talked about it should be much frequent, but then how it should be, this is a detailed plan.
We should properly counsel and prognosticate this patient at the very first visit. If we know she is a patient of heart disease, we should classify the type of heart disease, the etiology. She should have a proper checkup by a cardiologist also, and whatever medicines needed, they should be given. And patient should be clearly explained that her visits and to the clinic will be more frequent than that of a normal patient. So it is always wiser to call, every 15 days and later on till 28 to 30 weeks. And later on when the chances of this increases, so it should be a frequent visit, weekly visit. And in between, anytime she develops any complication, like she has fever, she has cough, or UTI or any infection, then she should be admitted and managed. Patient should be so advice, like these patients, heart patients, we always tend to say go for complete bed rest. But then complete bed rest itself increases the risk of thrombosis and all those factors. So we should ask them adequate rest, but not bed rest. Yes. Diet should be proper, and as we give a supplementation of iron and vitamins, that should be there for the proper health. Proper hygiene, any infection should be taken proper care, and it should be taken seriously because it will lead to serious complications. Then salt should not be omitted completely, but we can ask them to restrict the salt intake. And as like in all patients, avoid smoking, avoid alcohol, any drugs, beta-mimetics especially because they tend to compromise the cardiac function. And early treatment of any comorbid condition that should be taken with very cautiously in this patient, be it PIH, be it GDM, or any other comorbid conditions. Infections, as I've already stressed, they should be dealt with immediately. If the patient is of rheumatic heart disease, ma'am, then prednisone prophylaxis has to be given. And diuretics in pregnancy, it is best to avoid diuretics because they have their own complications.
Yes.
And rest, she should be advised, she should be admitted in time, and labor should be managed with great caution.
Yeah.
We should not have prolonged labor and full aseptic precautions to be maintained. Again, methergine is to be avoided at the time of delivery because it will cause cardiac overload. And if needed, then C-section in a tertiary center with proper ICU backup.
Right. So do we have Dr. Yogesh here? No. So when should be the admission? That will be, according to the NYHA classification, as you have already talked about the antenatal care. The 2 weeks before EDD, as you said, it will be for class 1, but class 2, that is class 2 onwards, is 28 weeks onwards you have to hospitalize, and class 3 and 4, the moment you diagnose the severe heart disease, you have to hospitalize, though you have to allow them the movements and proper ambulation and the nutritious diet, everything, but you have to hospitalize them, or maybe keep in close monitoring. That is what is advisable. Emergency admissions, they're like deterioration of functional grade. Anytime you feel that she was only the grade 1, but now her symptomatology is worsened. So it's a dynamic grading. So that you have to every time reassess, and then of course the symptoms and complications. So Dr. Savita, do we have
Yes.
Madam Savita? Yeah.
Yes, sir, I am here.
Would you like to induce this patient, or would you allow her to go into spontaneous labor? What would you prefer? Or what do you do?
Induction in cardiac patients should not be done until unless obstetric indication is there. We should wait for the spontaneous labor. They should go spontaneously into labor. If in the induction is required, then we should give the concentrated dose of oxytocin. If the Bisop scoring is good, if the Bisop score is not good, then the mechanical stimulation by Foley's catheter induction should be done, and along with that, the concentrated Syntodip should be given, and with PG gel, Cerviprem gel, and among the misoprostol, PG gel should not be used because it causes a sudden contraction and increases the cardiac output and the overload on the heart. So it should not may lead to pulmonary edema. So it should not be given.
Misoprostol. Strict no to misoprostol. Right?
Misoprostol should not be given.
Right.
So
coming
mechanical
to
stimulation and the concentrated Syntodip should be given for the induction if required. Otherwise, we should wait for the spontaneous labor.
Perfect. Perfect. So what are the poor prognostic factors, Dr. Vidya?
Yeah, madam. Actually, pregnancy with heart disease is having the guarded prognosis, but there are some factors. There is heart disease is a very poor prognosis. Most important, as we are told, the NYHA classification 3 and 4 has a bad prognosis or very poor prognosis. If there is any history of heart failure or the history of ischemic attack in the previous or arrhythmia, stroke, these are also the poor prognosis. Patient is having the poor prognosis. If the mitral valve area is very constricted, stenosis is more or less than 2 centimeters square, or the aortic stenosis is there, then it is also having the poor prognosis. Ejection fraction, left ventricular ejection fraction should be the more than 40%. If it is less than this, then it is also associated with the poor prognosis. And as we told, the severe condition where the pregnancy should not be there, like the primary pulmonary hypertension, Eisenmenger, or the Marfan syndrome with the aortic root dilatation. These are having the very poor prognosis in the pregnancy with the heart disease cases. Or the congenital heart disease,
So I think
is the more poor prognosis.
We have discussed 3 cases in depth, in details, and all of you have contributed so well. I think we should stop, right?
Yes, ma'am. It's late now.
Yeah, that is why. I have lots of very interesting cases, venous thromboembolism, etc. But definitely, I have shared the presentation with all of you. So I would, of course, I mean, I'll be happy. All of you, please go through it and, of course, implement it. I'll be happy if I can contribute something to your practical knowledge. So,
yes, madam, it's very good. Peripartum cardiomyopathy is very common. I think so many patients are coming with this.
Yes. So
thank you so much. Thank you so much.
Yes, I thank all of you. And please,
best wishes.
Please do support me in my endeavor. I'm your own representative as a common Foxian, practicing obstetrician, and working very hard, not only for the Foxy, but for Foxians and for Foxy community also. So I request all of your supports and votes. Please do campaign or canvas for me.
Sure, ma'am.
Okay,
Thank you so much, ma'am.
Thank you, Dr. Sneha, so much.
Thank you,
We will
ma'am.
fully
We'll
support you.
also
We will fully
ensure that our
support you.
members vote for you, ma'am. That voting is done.
Best
We'll
wishes,
ensure
ma'am.
that also.
Best
Yes.
wishes, ma'am.
You know
Yes,
that for me, there is lots of appreciation. But election is all about number game. So please do make sure that all of you vote. Thank you so much.
Yes.
Thank you
Our
so much
vote is
once
with
again.
you, ma'am.
Thank you, dear.
Thank you so much, ma'am.
Thank you, everyone, and wishes to Sneha ma'am once again. Thank you all for being till the end. Thank
Thank you
you.
so much. I thank entire UPCOG and all the society president, secretaries, all my panelists who have, contributed. So thank you so much.
Thank you, ma'am. Thank you so much. Thank you.
Thank you. Bye-bye. Bye.
Bye now.
Thank you, Sahiti. That was wonderful. Thank you so much. Please bear with us now. This month we will have little more programs. Thank you so much.